involved with you at this stage to go forward. So so we're there at this stage, and we're going to spend the next 2 days working with you through this process, and we try to make it as pleasant as we possibly can. So we're going to go to the next slide, and I'm going to press on. Yes, so as I said, yes, so this is the idea of today's event. Where we can, we're going to show you very much so our solutions that are work in progress at this stage. We're going to try to listen to you, get feedback, and from the feedback we gather, we're going to try to obtain the knowledge and use the knowledge to strengthen what we're doing. So there are 8 projects, I said, we'll go through them in a few minutes, but each project is at different stages. So the value of today is very important because it gives us an insight, a unique insight, a contribution from you as to how this can go. And here's like a little example. This is, you know, they say a picture can paint so many words, but here it is. We have like developers. They're trying to put together what they think is needed. But the users, as you can see, we have the cats just showing how different things are. So we're trying to very much so use today as a means to try to strike an understanding and make sure we come up with solutions that are really needed by the users during the process while going forward. So this is part of the initiative. I think the picture works quite well, and it's clear for everybody what we're trying to get across from today's meeting. Can we go to the next slide, please? So what are the issues involved? Well, we are in our 8 projects, and you can see them on the right-hand side, all the names from Faith all the way down to Rebecca. These are the projects that are involved in this cluster. And we're working across a number of areas from breast to prostate to lung cancer, melanoma, all down to anxiety and depression. So these are the subject matters of basically what each project's or the project's collective unit is going through at this stage, and we're looking at that. And if you go to the next slide, you'll see very much so the types of issues that we, I don't know, every patient is different, but we all go through severe issues from depression to the quality of life to cognitive impairment, fatigue, mental well-being. These are all as part of the subject matters that also these projects are looking at, and we're trying to make improvements to the quality of life of the individual as they move forward in the post-cancer treatment process. The next slide, please. So here we have the projects. And today, in day 1, we will look at 6 of the 9 projects. So Rita, who is operating the slides at the moment and working with us today, and I'll explain exactly the roles of people later on, she will present her Meniere project. And this is looking very much so at the area of mild anxiety and trying to assist them. They're looking at very much so conversational tools in that area. Then we have the Persist project, and this is a project that we will look at as well later on, and they're dealing with big data technology, trying to make change to care delivery for cancer survivors. Then we have O'Connor Relief, and O'Connor Relief is another project that's in the AI space, and it's important. It's trying to improve the quality of life and assessment improvement. And there they look at retinal cancer and also leukemia. And then we have the FATE project, which I'm part of, and this is looking at wholly breast cancer and lung cancer, and it's using federated learning to try to make that happen in there. And then we go to LiveChamp. LiveChamp is looking at the older cancer patients, and they're trying to put in place monitoring tools to improve the quality of life. And again, big data analytics and AI are very, very important, that one. And then the last one is the quality of time, is Quality Top. And it too is looking at human therapy, and they're looking at the CAR-T2 cells and looking very much at the area of leukemia. So as you can see, all these projects are looking at different areas, all in the same space. And what we do as a group, we try to see what are the common problems, and then we try to come up with common solutions, and we work as an entity to try to make our work better along the way. And this is what we're going to look at today. Later today, we'll also have a roundtable, and I'll explain that to you later on as we move forward. If we go to day 2, which is the next slide. Next slide, we have the pleasure of introducing 3 projects, and these are Clarify, Aspect, and Rebecca. The Clarify project is looking very much at the area of lung cancer, breast cancer, and leukemia as well. And it's gathering a lot of information to discover the risk factors that may deteriorate patient condition. And there's one hospital involved in this one. So their clinical trials have been very helpful as we move forward. So they're helping all of us as we move forward with our projects, which are slightly behind in terms of schedule because we started later. Then we have the Aspect project, and it's looking very much so the area of wearable, collecting active monitoring data from the patients, and they're using that knowledge to try to improve the quality of life with the Aspect project. And then there's the Rebecca project, and this is very much so looking at it here again, multiple wearables and how they can use the data to kind of strengthen, specifically looking at the whole breast cancer recovery area. So that's day 2. If we go now forward to the next slide, please. So this is the day's schedule, and as I said, we had a little bit of hiccup start in there, and I'm really looking forward to getting this moving as we go forward. And you can see we have quite a number of projects. As you can see from our previous discussion, we will go through the 6 projects I mentioned earlier on slide, and I have the pleasure of introducing Gerd Murphy next, who will speak, who we can see is on the line, and Gerd kindly came to our Media Minds event, the very first one, and spoke so well and had so much to say that it was very welcome to have her here today, and we'll hear to her very much so straight after this. But towards the very end there, you see session 9. Session 9 is where we're going to have a round table. What we're going to try to have here is get a discussion going, inviting the audience to use the chat to raise some questions. We're going to try to get some questions based on what the audience would have seen up to this moment of time. And then likewise, we will also have some questions from the project. So at there, we will have a number of patients and caregivers. There are 6 in total, and they will sit, and Panos will moderate that whole session. And I think we're going to find that quite an enthralling event. And again, it's all about sharing knowledge, sharing understanding, and trying to strengthen what we're trying to achieve with our projects. And we bring the knowledge forward to strengthen our solutions as we move forward. So the patient, the impact is very important. The feedback we're going to get is very important today. And that's just today's schedule. It's quite intense. I know we're running slightly behind schedule, so I'll move as quickly as I can to the next slide. So now we go to the second day, and we'll have the pleasure of listening to the Barbara Kirsten tomorrow. What Barbara is going to be doing is she's the head in the Research Innovation Unit in the European Commission, and she's going to give us kindly an understanding of the involvement of patient at policy level, at research policy level. So we will have the pleasure of Barbara with us tomorrow to go through all this process, and then we will look at the other 3 projects that we spoke about earlier on: Aspect, Rebecca, and also the Clarify. And this is it. Now, as you can see, from day 1 and day 2, we will have tea breaks. As you can see, day 2 in front of us, and likewise, we take lunch breaks, and then we'll also go forward with that kind of process there. So it's a full day at all times. When you leave, just stay open and then come back and join us. So that's just today's rundown. And if you go to the final slide, I think we know. So this is going to give you some rundown. So how we will manage today's event, it's more like a bit of housekeeping. Sarayda, who is hosting us today, I'm very grateful. And I'm sorry there was some confusion this morning about the way to connect on, but I think we got the problem solved at this stage. So we will be showing some presentations, and we'll be giving some demonstrations, and we'll be holding poll questions as well. So not all presentations will have not all projects will have the poll questions, but they'll be coming through, and Despina will be managing that for us, and that's really good. You're all muted. I think that's very important. Only the speaker will be allowed to speak to it. During the Zoom chat facility, please use it. Please be interactive. We will not use the hand. We try to capture as many questions as we possibly can, during the Q&A session. So if we take the very first one, what will happen is Gerd will come on. She will present her perspective, and once she's finished, we will have about roughly 10 minutes where we can start trying to entertain as many chat questions that may become, and we get the engagement going process going at that stage. So there'll be 30 minutes in total for everybody. And as I say, just being very much so kindly is on the chat, and we go through there. So that's just my quick introduction. I'm sorry we were slightly late and we had to rush it a little bit, but I hope it's reasonably clear. I think we could just go to the next slide, next area in the. Oh yes, just to remind you, sorry about this. Tomorrow we change link. We had a little difficulty today, so I hope tomorrow we won't. We go on live again at 10 o'clock in the morning, CET time, and this is the link through to tomorrow's session. And likewise, this is the password, but we will show you this again before we wind up today, just to make sure you have it. And likewise, you should be getting it automatically through your emails, which Alexandra, who's been kindly working on, has done that as well. So that's just a quick reminder for tomorrow's link that we go for there. So now we go to the next slide. And I have the warmest pleasure of kicking this off properly with Gerd Murphy. Gerd, I know you're on the call. I can see you semi-smiling there, so great to see you again. Thank you very much. Now, what Gerd has done, Gerd is a psychologist nurse that she's been, as I said earlier on, she's very much so been involved at the Media Minds first session. And there was so much said at this stage that it's just a pleasure to bring her back and to talk to us. And what she will do is give us an overview very much so of from a psychoanalyst point of view. So I'm going to now give the floor to Gerd.
Thank you very much, Tom. It's lovely to present here again. I'm presenting from a hotel room in Dublin. So I must apologise. I forgot my headset, but the room is nice and quiet, so there shouldn't be any issues. Yeah, so I just wanted to talk to you all today about the impact of cancer on patient mental well-being, and really give you a perspective from my own experiences working in the field of psycho-oncology in Ireland. Next slide, please. So just a little bit, I suppose, about psycho-oncology. Psycho-oncology is a multidisciplinary speciality focusing on the psychological, social, behavioural and ethical aspects of cancer care. Psycho-oncology is quite a new field in the sense that it really emerged from around the 1970s. Prior to that, cancer itself had a lot of stigma attached. Cancer wasn't discussed openly. Often doctors wouldn't communicate the diagnosis to people, to individuals. And also dealing with the stigma of cancer, there was certainly very little effort went into managing the psychological aspects of cancer, because really you were dealing with a double stigma. You were dealing with stigmas related to cancer diagnosis, and then stigmas related to mental health, you know, pre-1970s Ireland and the world really. So as cancer, I suppose, treatments, as cancer research improved, the discussion around cancer became more open. People would share their diagnosis, openly discuss, and there, I suppose, we learned of a significant psychological and mental health impact to cancer care. So that really was the beginnings of psycho-oncology. Psycho-oncology services in Ireland are very, I suppose, disparate in the sense that we have only had our first psycho-oncology model of care developing since 2020. So that's the, when you think, you know, when you think of the significant difficulties that people who have a cancer diagnosis have experienced, yet it's took till now really for the Irish healthcare system to look at that, identify that there's a lack of standardised care, there's a lack of quality of psychological care for people experiencing a cancer diagnosis. And this is our attempt now to make up for that, to deal with that. So I'm very much involved in the National Psycho-Oncology Programme, hoping to improve the standard of care for people living with cancer and beyond in Ireland. Next slide, please. So again, just to briefly say, you know, the psycho-oncology aspect of care really addresses the two specific dimensions of cancer, in that it addresses the individual, the psychological responses the individual has to the cancer diagnosis at all stages of disease, but it also addresses the psychological, behaviour and social factors that may influence the disease process. So it's a two-way, I suppose, a two-way streaming that cancer, that cancer in itself can have a significant influence on mental well-being, but your mental well-being during a cancer diagnosis can have a significant influence on the disease process also. Next slide, please. Okay, so just this slide really just identifies, you know, and it's by no means exhaustive, I have to say that, you know, a number of psychosocial impacts of a cancer diagnosis on an individual. I suppose when we look at, you know, normal psychological responses of shock, fear, anger, grief, resentment, and so on, guilt, anxiety, frustration, and of course acceptance. We also look at we also see a lot of other issues such as existential concerns, worries about the meaning of life so far, you know, what's the purpose of life, what is the meaning of this diagnosis, life, what is life itself, you know, concerns about death and spiritual issues as such. And we see, you know, low self-confidence, poor self-esteem, poor body images as a result of sometimes the cancer diagnosis itself. Cancer treatments can be quite disfiguring, you know, so we see a lot of changes in body image. We see a lot of issues with loss of sense of self and the sense of identity that an individual held to themselves prior to diagnosis. So getting to know the new person and all the challenges that brings, and of course significant issues around sexuality and relationships. A big issue in cancer care I would see and would experience a lot with my individual service users is that sense of loss of dignity throughout the healthcare system. So that's it. So that's a huge issue. Socially, cancer can be a very isolating and lonely disease, even for those who are surrounded by supports and people, you know, they can feel very misunderstood, very lonely and isolated in the diagnosis. And then, of course, you know, many people experience a lack of appropriate supports, relationship issues, loss of occupation, not working, a big financial concern, and worries of being burdens on others. Next slide. Another thing it's important to note that mental health difficulties can occur at any time from diagnosis onwards. So any time during the cancer trajectory, I would experience working with individuals with significant mental health difficulties. In particular, a lot of distress around diagnosis, around commencing treatment, and then after treatment, when treatment is over and they're moving beyond treatment and the supports in terms of the health service supports dramatically reduced. That's a huge transition phase in cancer care. And then, of course, if someone is progressing, you know, towards palliative care, end of life care, again, has a lot of distressing factors. Next slide. So just to say, the prevalence of mental disorders in the cancer setting is definitely quite high. Approximately 1/3 of people with a cancer diagnosis, if assessed, would I suppose meet the criteria for a clinically significant mental health disorder. And then when individuals with cancer are given the opportunity to self-rate their distress, you're not relying on others to assess. 1 in 2 actual cancer patients report significant distress. So it's definitely a very important area that requires significant input and support. Next slide. When we talk about, I won't go through all this, but when we talk about distress in the oncology setting, the National Cancer Control Network in the United States actually coined the word distress as the preferred terminology in oncology services. So really, when we talk about distress in cancer, we're really talking about a continuum from, mild adaptive responses, transient distress that people cope very well with and may not need any additional support, to the more severe end of the continuum, where there are significant mental health difficulties, significant disorder that requires specialist mental health intervention. And it's just to not assume that that distress is a normal response to cancer treatment and therefore doesn't need any intervention. So as said before, the distress continuum really ranges from common, normal adjustment issues to then the more common adjustment disorders, such as anxiety, depression. And then what we see I suppose, as part of a specialist mental health service responding to mental health distress in the cancer services, we also see the less common issues, which would be more severe in nature, such as delirium, psychosis, mood disorder, cognitive disorder. And these are often related to the types of, I suppose, cancer and the types of cancer treatment. And then we also see more rare manifestations of psychiatric disorder in the cancer setting. Again, these are quite rare, so I won't go much into them, but these are really in relation to when cancer, the normal immune system kind of that activates against cancer cells can often, I suppose, for want of a better word, attack the central nervous system. And we can often see as well that the cancer can progress or metastasize to the lining of the brain and the central nervous system, which can often result in significant kind of mental health difficulty. Next slide. Okay, so what we know is that when there are unmet psychological mental health needs in the cancer setting, it has really quite a devastating impact on a patient's well-being. We obviously see reduced quality of life. We see negative clinical treatment outcomes, i.e. chemotherapy effectiveness. We see people who tend to have poor adherence or don't engage with cancer treatments out of whether that be anxiety or low mood, or just generally really poor coping without the supports. We see increased symptom burden and impairment, and it's generally, I suppose, an unmet psychological need is generally associated with poorer outcomes and mortality. And a big thing that for the hospital, for the healthcare providers, is we see an increased use of healthcare resources. I think one study kind of was able to link that individuals wish a significant anxiety or depressive disorder, on average, could cost 50% more in healthcare costs than an individual who, I suppose, you know, has well managed mental health during their cancer diagnosis. And then subsequently, when you introduce psychological interventions, you can see approximately around 20% reduction in healthcare costs. When we don't intervene early with mental health support, you see that more specialist psychosocial support is required at a later stage, kind of creating, I suppose, a greater burden on psychological services. And we see reduced pain and symptom tolerance or amplification of physical symptoms. So often, you know, I might get a referral from the palliative care team who are finding it increasingly difficult to manage pain and physical symptoms, but with specialist mental health supports, we can see improvements. And of course, we do see an increased risk in suicide in patients whose mental health needs are not met. And that's often an area that's not discussed in cancer care, but needs more attention, I would think. Next slide. So when we're looking at, I suppose, supporting people's mental health during the cancer, during their cancer care and beyond, then we really do, from a liaison psychiatry perspective, we have to consider the biopsychosocial approach to mental health and psychological well-being. To address one's physical needs alone will not, as we know, meet their psychological needs, and vice versa. You know, without addressing their physical needs, you know, there can still be unmet needs if we're only focusing on psychological and their environmental issues. Often patients of mine, you know, might be well engaged with support services, really well engaged with the cancer care services, but there's many unmet kind of social environmental needs within their family circle that's sustaining the distress. You know, that regardless of the amount of support services that are in place, when they're going home to the same maybe financial worries, issues with their children, issues with work, then really it's very hard for them to move forward, regardless of the amount of counselling supports we have in place, physiological supports we have in place. So really it's about understanding that the cancer and related treatments have a significant effect on the biopsychosocial well-being of a person, and then requiring greater understanding between the complex interaction between the biological, psychological and social factors of the disease, and that being the centre of all interventions for every caregiver in cancer care. You know, that it's not just people working in psycho-oncology, it's the social workers, it's the oncologists, it's the hematologists, it's the palliative care specialists, that we all approach cancer care from a biopsychosocial perspective. Next slide. Okay, so just discussing, I think this slide probably is one of the most important in the sense of starting to think about how the projects that are being showcased, I suppose, here today and tomorrow can really influence and support mental health care, psychological well-being in the cancer setting. In terms of barriers to accessing mental health supports, these are just a few of the issues that I come across regularly. The big issue, I suppose, we would see in Ireland, and maybe I'd be interested to know if there's a lot of countries represented here today, if that's the case in many other countries, is the lack of standardised distress screening. So there is no, currently in most cancer centres in Ireland, there is no screening for distress. There is no standard where the person at all points of care is assessed or screened for distress. So you're really relying on the individual practitioner who's involved with the person at the time would have a knowledge, an understanding, and an interest in the person's psychological well-being. So again, often we see many people's distress go unnoticed at the earlier stage, resulting in much more severe distress at a later stage. A lack of awareness of available resources. So a study conducted back in 2000, and actually there's been a newer one since in 2019 by a group of researchers, Smith et al. And basically not much has changed. Well, I suppose there's been a slight change. So back in 2013, the study found that only 40% of survivors reported having had a discussion with their clinicians about how cancer may have affected their emotions or relationships. So around 60% were never asked about their mental health or their emotional well-being during their cancer diagnosis. The most recent study in 2009 actually had improved slightly. 50% reported that they had never been, I suppose, asked about their emotional well-being during their cancer treatment. So a slight improvement in 6 years. So generally speaking, it's not dealt with at every possible intervention. I suppose from my perspective, every contact should count. At every contact with cancer care services, whether that be a nurse just about to take bloods, or into the day ward to administer chemotherapy, back for an outpatient's appointment, attending for radiotherapy simulation scans. Each and every point of contact is a missed opportunity to identify if a person is experiencing mental health distress. Again, then the lack of appropriate sources, again, as I mentioned in the first few minutes, is a huge issue in Ireland. There's no standards of, we're only developing standards of psycho-oncology care now, and trying to resource that amidst the kind of backdrop of COVID has been very difficult. So not all cancer care services in Ireland have access to specialist psycho-oncology services. In terms of those working in cancer care, the biggest issue that I hear of is time constraints. We don't have time. There's not enough time to, I suppose, to ask. They're worried that if they ask, they'll have to spend more time with the patient, and they just don't have that time to do that. But again, around making the most of your time and making your time constructive, often what I see is that the 5 minutes telling a patient that they don't have time to sit with them, or could be 5 minutes spent asking just a few basic questions to identify distress and then refer onwards appropriate. Then, of course, the place of care, the environment, it can be significant. If you look at a standard kind of chemotherapy day ward, there's a number of lovely, comfortable chairs, very close together. Maybe just a very thin curtain can be drawn if you need some more privacy with the patient, but that's not conducive to having a very open discussion about an individual's mental health or their coping. So then communication difficulties. Again, often carers are not good communicators, and often patients conceal their distress or underreport their symptoms. And just what I discussed earlier, the stigma, of having a mental health issue often people, because it's not openly discussed, or they're not openly given or provided information regarding what the possible mental health outcomes of their diagnosis is, they can often feel, they always say to me, God, I didn't realize that everybody experiences this, or I thought, I'm not doing well enough, I should be coping better. So a lot of self-blame of why that they're not managing or coping better with their illness. And then within the healthcare setting, one of the issues that I see can often mask mental health disorder is patients who present with challenging behaviour. Again, that really leads to the last point about lack of oncology care providers' education and training in psychological perspectives of oncology. So they may not understand or see what's presenting or interpret the behaviours that they're seeing as emotional distress, as someone putting up a hand and saying, I need help, but just doing it in a very different way with challenging behaviour. So really, again, the key message is that the lack of awareness and the lack of knowledge about mental health difficulties in the oncology setting, both among the service users and the healthcare staff, is a huge issue in my experience. Next slide. So this is actually the last slide, and this really, again, it's not exhaustive. These were just a few points that I thought that could maybe direct the discussion in terms of how these AI projects can improve mental well-being for individuals throughout the experience of cancer. From my very basic, I suppose, point of view, the reach that they have in the sense of being able to increase awareness is invaluable. Again, normalizing the experience of distress. So that key piece in reducing stigma, making the experience of distress a normal part of the cancer discussion, providing education and information. Again, very simple, but a key point that is very much missing in a lot of cancer services. And early detection. Early detection is key. When you look at some of the, I suppose, the programs that are looking at natural language, in terms of a person being able to, I suppose, diarise their experiences, and that these algorithms or these apps would be able to detect if there's a change in a person's mood. I mean, that has huge potential. And then, of course, the ability to alert and identify key supports to initiate timely and responsive interventions at an early stage to improve the ongoing kind of health outcomes and quality of life. So that's my brief kind of experience of the mental health difficulties that impact on mental well-being during a cancer diagnosis and thereafter throughout the cancer trajectory. And I hope that the last few points can just initiate a little bit of discussion around that. Thank you. Next slide.
Thank you very much for that enthralling presentation. Gerard will be with us for a little bit longer, but she's on vacation, and I think she's anxious to get out and enjoy it. Do we have any questions specifically for Gerard at this moment of time? I think we may have one. Sarita, do we have one? Yes. We've got a question.
Yes, Tom, we have one. Hi, good morning.
Hi, good morning, Sarita.
First of all, Jane, thanks, Gerd, for her excellent presentation. Indeed, we are also pleased of having you with us today, Gerd. And we also have one question from the chat. Leah Leroy, patients with brain tumors also have problems coping with a brain injury. Does this present additional problems for psychological support?
Absolutely, absolutely. So often when you look at specific brain cancers or brain metastases, so other cancers that have metastasized to the brain, an individual can experience really a devastating array of symptoms and side effects. We can have personality changes, behavior changes, mood changes, but also I suppose, not most importantly, but significantly importantly, cognitive changes. So how you respond to an individual who has experienced a brain cancer or a metastasis to the brain very much depends on an individual basis. And, that really does highlight the need for a very comprehensive mental health biopsychosocial assessment, in the sense that if someone has a significant cognitive impairment, either through the brain tumor or the disease, or often the impact of radiation therapy or surgical intervention, so big tumors which are debulked, it's a big surgery and it can impact on many, I suppose, parts of the brain that influence behavior, cognition, mood. So often the approach, for example, if someone has significant memory impairment, or difficult or cognitive impairment, it would be very hard for them to engage in, I suppose, a full psychological intervention such as cognitive behavioral therapy or psychotherapy. So it really is about tailoring it to the individual. Oftentimes we have to use medication to treat mood disorder or to alleviate distress, or to manage the behavioral aspects of that type of, I suppose, a symptom or side effect. So it really does depend on the individual, and highlights the need for a very comprehensive assessment, because without, I often see patients who have had brain debulking surgery, brain tumor debulking surgery, and they might be very quiet. And it really does. The cognitive aspects can be quite difficult to uncover. So often the healthcare providers don't even understand, don't even realise that they've had a significant impact cognitively, because they can pass themselves. As you can imagine, a busy hospital setting, a doctor going from bed to bed, a few minutes each. If someone can just say yes and no, and appear to be understanding what's been told to them, then often it goes undetected. So it just really highlights the need for a very comprehensive assessment, and then a very tailored intervention to their needs. Does that answer the question? Did I go off topic there?
No, I think you're spot on. Is there any other questions we have at this stage for Gerd?
No, but I think that we can warm up a little bit by asking you to enter the Mentimeter link. It is on the chat, or you can just enter from your mobile phone or laptop, tablet, whatever you use, the menti.com website, entering this code up here, 77 92 84 61, and tell us to which stakeholder group, from which stakeholder group you're coming from. Patient, researchers or scientists, policymakers, engineers, doctors or mental health professionals, or other. Okay. Can you see my screen, right?
Yes, perfectly well, thank you. We keep it up for a little while longer, then we'll switch.
Yes, we have 21 answers so far, and the number is increasing.
Yes, again, you can find the link in the chat. Yes, press the link and it will redirect you to the poll.
Many people are coming from the research sector, but we also have representatives from the other stakeholders groups, except for policymakers. I don't know how. We hope that we will have more participants later.
Okay. All right. So maybe we'll shut the poll down and just keep that. Yeah, and we'll press on a bit. Look, I know we're acutely tight of time as well, and I'm anxious that Gerard takes a break. She's on vacation in Dublin. So Gerard, with an honest heart, thank you very much for your time for today.
Thank you.
Pleasure's ours. I will link up you again next week, and we talk. But just for now, I'm anxious to get out and get a bit of sunshine that's outside in Dublin for a change. So thanks again for coming for this.
Thank you very much. Thank you all.
Okay, okay.
Tom, you're muted.
Thank you. We move on from to the next presentation, and this is from our colleague Sarita, who's been managing the slide presentation to date, and I'm extremely grateful. And Sarita she's an associate professor from the University of Granada. She'll be working very much so and leading the Meniere project. And the Meniere project is very much so focused on developing innovative conservation technology and promoting it during the healthcare and promotion well-being. So what we're going to hear from Sarita is information about the project itself, and I will pass it on to Sarita at this moment.
Okay, thank you, Tom. So today I'm going to introduce you to a research project, Meniere. Meniere stands for Mental Health Monitoring Through Interactive Conversations. And we all know how technology can assist us in maintaining physical health. So we have all sorts of different apps that tell us how to keep with physical activity, nutritional patterns, and we can be in control of that. But mental well-being is an essential component of health. So our vision is that technology should also help us achieve our mental health goals. Mental e-health applications have the potential to improve mental health literacy and facilitate access to useful resources to people who need them at different points of day and night. And they can empower users to manage their own well-being, offering trustworthy means of accessing health. Particularly in Meniere, we focus on using chatbots. So many of you are maybe acquainted to assistants such as Siri or Amazon Alexa, on these types of systems with which you can converse or use speech to interact with. Our idea is that this interaction is not only command-like, but it's more conversational. So we are working to define new user-friendly conversational interfaces to promote mental health and support users and also mental health professionals. So this has multiple benefits. On the one hand, the interaction is easier because you can just chat with the system or establish a conversation using your own language. And on the other hand, speech conveys a lot of information that it's useful to detect what's the emotional state. So the way we speak, the words that we use, how we pose these words when we speak, that it's a very good indicative of our emotional state. So this is very useful information that we can process, and this can provide several benefits, like supporting people who don't have very regular access to mental health or well-being services. This can be operative anytime that users may feel distressed. and it can help to favor early diagnosis, and also it could be an alternative when face-to-face interaction is overwhelming for some people. Meniere, it's Marie Skłodowska-Curie action, research and innovation staff exchange. This means that the objective of our project is to create a network of people who worked together towards the same goal in a multidisciplinary and cross-sectorial setting. So the idea is that researchers, academics, but also industry, mental health service, and non-profits with different backgrounds, background on computer science, on psychology, on cognitive sciences. We all work together towards this shared goal, which is to develop this innovative conversational technology. So we are 8 partners in Meniere, located in Spain, United Kingdom, Germany, and Italy, with a combination of academic partners, universities, but also companies and non-profit mental health organization. And we are all working together to develop this multidisciplinary and cross-sectorial network. Well, our project started in 2019 and will be running till 2024. So we are a bit more than in the middle of the way. And in this time, we have addressed multiple challenges. First challenge is how to be able to monitor mental well-being. So we've discovered that that using this kind of technology, some users feel less judged, so they can openly ask for help, and this would avoid that they conceal this distress. We found this in collaboration with the users, with the final users. We've also been studying what are the verbal and non-verbal cues that can be used to detect anxiety and mood cues on speech, and also how we could make the technology, the chatbot, be able to show what it has been learning along the way. So what we've learned so far is that chatbot can support self-disclosure, and we've recorded a corpus from which we've discovered what could be the relevant cues in conversational behavior, verbal and non-verbal cues that can be used to identify anxiety, mild depression, and we've also discovered from our users the importance of personalization in the way that the chatbot poses the information to the user. The fact that the system can monitor the well-being of the user, it can be tricky, so we must find a balance between having frequent monitoring but also not being a constant reminder of mental distress. Another challenge is how to signpost useful resources. So we've been compiling different mental health coping strategies, relevant digital content and resources that we can make easily accessible to users because they can just ask for it. They don't have to, let's say, press keys and go along different menus. They could just engage in a conversation. And also we've been addressing the challenge of adaptation and personalization, how the chatbot and the way the chatbot converses, it's adapted to the users and their progression and previous interactions that they had with the chatbot. So this is a key aspect in which we are working at the moment. And we are doing it in collaboration with the clients of Action Mental Health. And pillar to Meniere is good practice for data collection, privacy, data sharing, but also very importantly, participatory research. And I think this is a common thing for all the projects that are part of the CSAAP AIW cluster, we are all very focused on involving the final users of the technology in the design, in the development of the technology. And so we've also adopted this co-creation approach. We must not forget that the aim of Meniere is to train staff in this multidisciplinary setting. So we've generated different dissemination and communication materials, and including training material that we are sharing through our website. And just to give you a better picture of what conversational technology, what would be the scenarios in which it can be used. These scenarios were co-created with the final users in our project. And some of the main scenarios are, on the one hand, to motivate users to follow an action plan. So we don't understand motivation as something abstract, like saying, okay, you can do it. What we do is to set a plan. So the users have objectives, and we help them to achieve these well-being objectives through different activities that are part of this action plan. And so this plan is set in collaboration with mental health experts, and the conversational technology helps users to engage in the plan and keep motivated. We are also, as I was saying before, have collected different useful resources that are made available to our users. And also we have a journal in which the users are able to talk about their day, and this information, for example, the information in their voice, the tone of their voice, the volume, and all different cues are processed in order to identify their emotional state. So we are currently running in parallel all these scenarios with different Meniere partners working along them. And in the slides, you can see what's more or less the more technical side. Like we have a website in which we have all the action plans, and this is accessible to the users and also mental health experts. And then through their mobile phones, they can interact with the chatbot that takes into account the peculiarities of each user, their objectives, how they are progressing in their plan in order to conduct the conversation. Here you have also some recent advances. I hope they are not too technical, but we've analyzed different mental health systems, and in particular those which entail conversation with an agent. We've also recorded human-to-human interactions to teach our technology how to behave like humans and to understand human behavior. So in order to do that, we had to record, transcribe, and annotate all this information and then analyze these conversations. We are still analyzing them, so there's a lot we are learning from them. We've also conducted different perceptual studies, like, for example, what would be a good synthetic voice for the chatbot. And we've built this user model that can be used as a basis to personalize the interaction. One of the things that we do is to remind the users about the activities, and this reminder change depending on they are personalized to the different users. So in the near future, we will continue advancing, hopefully with your feedback. So we will continue studying the acceptability of mental health chatbots, whether they are usable and they are helpful for users, how to best check the progress of the user, how to adapt dialogue to the information that we can have about the users, what are the best means of communication, and then how we can generalize our results to different user groups, and also continue working on more communication activities. So thank you for your attention.
Thank you very much for an excellent presentation. What we're going to do now is just do a quick poll, if possible. We just do a quick poll and get that done now, and then we're going to take questions and answers coming from coming into Zoraida at this stage. So we do the poll, if you can, please.
Sure. By using the same link and the code, you can just answer the first out of the two questions posed by the working team of Meniere project. In the meantime, we have some first questions and comments on the chat for Zoraida. Okay, the first question is, do you see conversational systems like mobile assistants such as Siri or smart speakers like Amazon Alexa in your daily life? Frequently, sometimes, never, neutral, do not know the possible answers.
Thanks, everybody.
Zoraida, please feel free to comment if you want on the live results that we receive.
Yes, so we wanted to check what people usually use these systems. So one relevant aspect is the perceived usefulness. So maybe, and that's in relation to the second question, maybe we do not use an assistant because we don't see that the functionality that it offers is it's interesting for us, but maybe if it can be helpful, we would be ready to, we would be considering adopting it, which would be more in the line of the second question. Yes, so I was...
Right now we are passing to the next question, again by Meniere project team. Would you consider using a chat box such as the one proposed in Meniere to help you improve or manage your mental health? I would use it, I would consider using it, it would not use it, neutral, or do not know, again, the possible answers. In the meantime, Jane comments in the chat that you could also check the behavioral change theory model by Missy et al. Sorry about the name. Also, Lucy Wardley's relevant work on the person-based approach. Thank you very much. Sotiris Diamandopoulos is commenting on data privacy. Data privacy can be an issue when adopting health-related AI technologies. Yes, and this is an issue that will be raised also in following polls and other, and also in the afternoon roundtable session.
Yeah, so thank you so much, Jane, for the pointers. We will, yes, I will go through them. So I'm taking note. So thank you so much.
And
yeah, and
there is also one question to you, Zoraida.
Okay.
From America. Is cultural diversity taken into account to identify verbal and non-verbal cues during the interaction to detect anxiety or mood cues?
Yeah, so this is something that it's really important, Erica, I agree, to consider the differences in cultural background, even age. It's very it's also it affects a lot speech patterns, so we are considering it, but the problem is to find the data to make a balanced training that considers all these different possible backgrounds. So maybe we can link up afterwards in case in case you're working on this same topic and maybe you have some resources that could be useful, because we are really, we are considering it, but we are having this, let's say, practical problem of having enough resources for training with different backgrounds. Yeah.
Thank you all. Thank you, Zoraida. And Tom, the floor is again yours.
Thank you, guys. Zoraida, Svenny, thank you both for that. One question, just Zoraida, in terms of the algorithms, do you think at this stage that the ordinary person is ready to accept the results coming through, or do they think that it's fake? I've seen people saying we're not ready to trust the algorithms at this stage. Do you think that's an issue that's out there at the moment when you're dealing with in the project?
Yeah, so here there are different aspects that are important. On the one hand, that you can trust the resources that are suggested by for example, in our case, the chatbot. So we know that you can sometimes look on the internet and find something you don't have you cannot always trust what you find. So the fact that we are compiling this corpus of resources that have been double-checked by experts, I think this makes it possible for the users of the technology to trust the suggestions. On the other hand, there is the issue that about why do the systems based on artificial technology do what they do, and this is explainability, that the system is able to explain why it took certain decisions. So in our case, in the particular case of Meniere, the system is always supporting, let's say, the plan that has been set for the user. So it's supporting this plan. So it's not, let's say, making a decision for the user or a decision for the mental health expert. It's always a support to keep the users motivated and then can access information. But in general, it is very important that there is explainability in systems that are devoted to health applications. We must know why the system is suggesting a thing or another, and this is, I think, key. Yeah, it's crucial. Yeah.
Generally, do you think people are more at ease with the technology at this stage? Do you think we've reached that stage in the evolution, or do you think there's still mistrust there at this stage?
I'm not. I don't know really what would be the answer to this question. When we've discussed with our final users, the people with anxiety or mild depression, with which we are doing the co-creation design of the system, they were on the one hand positive about the benefits that this technology could bring, but they were also they also raise these kind of questions, and I think it's healthy. It's good that we ask about the technology, that we require the technology that we use, that it's designed with privacy, following ethics rules. So I think we are all in the same boat for this in the projects that take part of the cluster, and we are doing great effort towards this line. So I hope that we can, let's say, communicate this to the patient, or that are the final users to the technology. So, and I think that's why it is so important that we develop it with them, because if they are part of the development process, they will see how we do it and how we pay attention to all these different details. So it's not something that comes already finished and we send to them, but they are engaged in the process. And so events like this, I think, are very important, because this way we can communicate what we do and how it can be helpful.
Thank you. Sorry,
May I add
we're
something?
having this event. You gotta go. Go ahead.
May I add something? My name is Anna Esposito, and I don't know if you can hear me. Can you hear me?
Can. Yes.
And I am in the Meniere project too. I am one of the partners of the Meniere project too. And because I want to say something more about cultural diversity, because we were trying to analyze cultural diversity. Like Zoraida said, we are collecting some research on cultural diversity. We have data for Italian, we are trying to collect data for Russian, but cultural diversity is something that not only require this resource, but also different technological resources, such as automatic speech recognizer for that language, dialogue manager for that language. So there is an added complexity to this. And clearly, it must be accounted for. So it's not something that can easily. So it's surely interesting to look about the difference in cultural diversity. And this is an attempt, but it's a long way to go. That's what I want to say.
Thank you, Anna, very much for that. We got one more question, and I think we're going to take a short break. We got a question in from Esperanza Johnson, I hope I pronounced it correctly. What approach have you used to detect anxiety and mild depression? Has it changed throughout the development of the project?
Hi, Esperanza. Thank you for your question. Yes, so we are doing several things. So we've studied the speech patterns. So I don't want to be, your question requires a technical response, and I don't want to be too technical because the audience is varied. But yes, we try to use the way we speak. So this is one thing, like tone of voice and things, speech patterns. We are also taking a look at language, like the vocabulary that we use, but also we also are considering the conversational behavior, which means if I am in a conversation, do I speak for a very long time? Do I change turns very rapidly? What type of conversation dialogue acts, if you may know what it means, but what type of objective do I try to achieve with everything that I say? So all these things are being considered. So conversational behavior, language, and speech patterns. That's what we are using.
Right, and thank you very much for that. I think we'll close this session now because we're running short on time a little bit. We are going to take a quick tea break, and then we'll come back at 11:35 CET time. Sorry, 11:50 CET time. We'll come back at and we will then move to the live chat project, which is Antonio's, and so I'm kind of looking forward to seeing you all again in about 10 minutes time. So just a short break, and we'll kick back at 11:35. So hope to see you all then. Thanks now. Bye. Welcome back, everybody. We're going to move to the next session, section 3. This will be Panagiotis and also Antonios, which is good. Now, while we had a little tea break, we thought what might be very interesting is when we get a Q&A session, by all means, we can go through the chat questions. But if somebody wants to speak because they want to talk or join the conversation, I think it would be fine that we do that as well. So we're going to try to start that as well. We're going to let people to do that. So I'm pleased to say I'll give the floor now to Antonios, and we go from there. Antonios, the floor is yours.
Okay, so let me share my screen. Professor Panagiotis Bamidis, who is the coordinator of LifeChamps, will initiate the presentation, and then I will follow up.
Hello, good morning, everyone. While Andonis is sharing his presentation, let me say that we are thankful to all the projects for handshaking, basically, in this common endeavor, for joining forces to use technology for well-being, but specifically for the well-being and the improvement of quality of life for cancer survivors. So the LifeChamps project is one of those projects funded by the European Commission, and referring to integrated cancer care and specifically focusing on the quality of life for older adults, for older cancer patients. We focus on 3 types of cancers: breast cancer, prostate cancer, and melanoma, and specifically after the treatment. So we don't discuss about diagnosis, but after treatment. This is a 10 countries wide project, basically from 15 partners composing the consortium. As you see, geographically arranged around Europe. And if you can have the next slide. The key societal challenge that we focus is to play with this, to do something about this aging stigma, basically. As you see in this little graph providing some information on one country's data, the age of the diagnosis for the cancer treatment is relatively older, and that calls for something which is the risk of cancer, which is increasing with advancing the age. However, if I can have the next slide, current practice suffers from this specific stigma, basically, the ageism, as I will call it. There is insufficient care to support older cancer patients, and therefore this creates inequity, basically, with access to cancer care, and that leads altogether to poorer outcomes. There is little data on the interaction between the role played by frailty and the cancer diagnosis and treatment, and the combined effect and impact they may have on the quality of life of older cancer patients. So apart from a defragmentation in the model of care that this is producing altogether, it does produce an unknown bunch of parameters and things that we would be interested for a number of reasons to explore. So here comes the LifeChamps project in the next slide as the solution based on big data and integrated care solutions for specifically for geriatric oncology. So what do we try to do? We try to collect data from different gadgets and different digital medicine solutions to create those digital biomarkers, including those reported, self-reported symptoms and measures and experiences from patients and care providers, caregivers. All these are collected into a big data infrastructure with high performance computing enablers. And hopefully it will create a kind of analysis, multimodal analysis that will provide good indices based on the frailty phenotypes on digital frailty indices that we hopefully will be able to classify pre-fail, fail, or fit sort of classes on these three different cancer types that I mentioned. Obviously, and that will be shown in the next few slides and things that Antonis will share with you later on, we are also creating a recommendation application, an app that is going to be used by patients to educate them, to make them aware of how their status is progressing, and also an analytics dashboard, which is probably going to be more useful for the healthcare professionals. So this is where we are at the moment. We have been developing the technical background and studying the protocols and developing the protocols that were going to be used, and we are just about ready to bounce into the clinical collection, pilot data, baseline data, and stuff like that. So Antonis, you may take over the rest of the presentation.
Thank you, Panos. Briefly here, you can see the patient application for quality of life assessment and the different sensors that we use as a means of collecting data and interacting with the patients. So you can see here on the left side, different parts of the application. More specifically, we have questionnaires regarding the patient-reported outcome measures of patients, like quality of life or symptoms, symptoms burden, etc. Also, there are a couple of exercises that help the patient deal with their anxiety, like breathing exercises or listening to the music. There is also an educational unit, several educational units embedded in the mobile application, which allows for the patients to go through it and try to understand better and be empowered regarding their daily life and how to deal with everyday problems, issues that are coming from their treatment or the different comorbidities that are there due to age. And there is also the possibility to have some quizzes that help better, let's say, digest the educational information provided by the application. Also, there is a part in the mobile application where we increase the self-awareness, a paradigm of what we call as quantified self, where the patients have the possibility to collect data from sensors and, like, for instance, a wearable device, a fitness tracker, and try to visualize all this data and better understand how their health and quality of life evolves through time, and try to, let's say, figure out how this data might have an impact on their quality of life. So apart from the mobile application, the patients also are using several devices which are either passively or actively monitor their quality of life. The devices that we have integrated so far in the LifeChamps platform are a fitness tracker, a Fitbit device, a smart scale. Also, there are some unobtrusive home ambient sensors that are being placed in the different rooms of the patient, and also some smart devices, smart home devices like smart plugs that can monitor the usage patterns of a patient. For instance, when they use the TV and they watch TV during the day. And there is also a smart textile, as we call it. So it's a t-shirt which can be used in order to measure vital signs in more detail. So this t-shirt, some sensors are embedded on that. And we also, for the melanoma case, we also have the option to monitor the radiation exposure, the UV radiation exposure of melanoma patient through an open service, which is called OpenUV. So how do we aim to use this data in order to extract knowledge out of it and to better monitor the quality of life of patients? Actually, we are going to extract meaningful features like that are actually part of the patterns, the behavior patterns of patients. For instance, we can use the smart plug sensor in order to monitor activities of daily living, such as watching TV. So how often a patient watches TV, or what times during the day or during the weekends. And we aim to study this longitudinally to see changes, meaningful changes that can be mapped possibly to quality of life domains relevant to frailty. Also, the working activity of the person, and how do we monitor the working activity of the person indoors is by using these ambient sensors that can track the activity, the room activity of the patients. And so we can see transitions between rooms and identify different patterns during the day. For instance, we can have a pattern for prostate cancer patients that probably increase their visits to their toilet during night. So that might be an early sign of some health deterioration or quality of life deterioration. So all these patterns, we are going to try to map them into different quality of life domains. And this way, we are going to try to create what we call quality of life behavior. So apart from the mobile app for the patients, there is also a part that is destined for the clinicians, for the healthcare professionals. So all this information we'll try to provide, to process them and provide meaningful insights to healthcare professionals, but also to nurses and people that take care of older cancer survivors after their treatment. So this LifeJump dashboard is being comprised by 3 components: the web application patient level monitoring, where actually the clinicians get to see longitudinally what is the progress of the patients in regards to the different parameters that we have, that we can collect through the mobile app and the sensors. Also some kind of trajectory modeling, so we can see whether there are meaningful changes that can be mapped to specific clinical indicators. And there is also the possibility that each clinical site can have statistical analysis and indicators that have to do with the service that being provided by the specific pilot site. So a population-based, let's say, analysis. Here you can see some examples of how this patient-level dashboard may look like. So currently this is, as Panos mentioned, under progress, and here you can see, for instance, several information that is being displayed specifically for each one patient, like the different answers that are being provided through the patient-reported outcome questionnaires. Or here you can see on the right side some information regarding the activity levels of the patient or their sleep quality, information that is being provided through the fitness tracker. Here you can see an example of how the cohort level might look like. So this is exactly what we meant by saying that we try to analyze data and aggregate data on a population level. So here the professionals can have a look at their patients, how the quality of life of patients, and see also interactions between different components, let's say, of quality of life, or different patterns. So for instance, here you can see that you can have a pattern of a room-to-room transition, for instance, in the home, which might correspond to frail or non-frail patients. So here, this is how we can visualize this. And of course, there are other multiple views for like statistical features or other features that could discriminate given different filters or different criteria of this diverse, let's say, population, like the older cancer survivors. Of course, the models that we plan to develop, it's not solely dependent on data. We also try to, in order to make our models being trusted by the clinicians themselves, we try to map the different, let's say, factors that are related to frailty or the quality of life with the help of clinicians. So we perform several focus groups, online workshops, where we try to document their input and their feedback and try to adjust both the development of the models, taking into account specific input parameters, or even the way that we visualize our outputs. And this is, and I will close our presentation with this message. It is important also for this cluster event to highlight that these technology projects, in order to move forward, we need to go through a procedure of including as most stakeholders as possible. And this is what we are trying to do since the day one of Lifetime's project. We have been involving since the beginning of the project multiple stakeholders, EU-wide, like patients associations and representatives, healthcare professionals, scientific communities, and also caregivers, and also researchers. So far, we have managed to make a close collaboration with ECPC, which is the umbrella organization of cancer patients throughout Europe. They are also a partner of this consortium. And as an advisory board member, we have managed to have on board the International Society of Geriatric Oncology, to whom we are pretty much thankful for their support and their advisory role they have in the project, and all the communications we had so far in order to provide the most meaningful outcomes for them as well. Thank you very much. That's it from our side, me and Panos. So we're open to questions.
Thank you, Donis. Thank you for your attendance.
In the meantime, we will share the poll with the questions from the Lifetime's team, and of course, feel free to raise your questions to the two speakers. We'll go back to the Mentimeter again. The first question is the following. Based on what you have heard and seen, how important and meaningful do you consider the information collected from the sensors for quality of life? To great extent, somewhat, little, neutral, or do not know, not at all.
Panos, you are muted.
Yes, what I was trying to say is to underline the last couple of slides that we presented, the importance that we envisage on the collaboration with patient associations and communities of practice, basically. And we have been practicing this in this project from day one, and we are still practicing, obviously, now that we embark on the pilots. But I think it's pivotal in the sense that whatever we're going to do, the sensors, the dashboards, the apps, they have to be patient-centered. Otherwise, they might be rendered useless, and therefore they might not have any impact at the end of the day. So we are collecting information and co-creating solutions with them so that we can target at better outcomes at the end of the day. Obviously, these outcomes will be put also on economic effectiveness and efficiency angle, which we are now going to start doing in parallel with the pilots. But the quality of life of these patients is a central parameter to that evaluation as well.
Tom, you mentioned earlier on that there was a stigma attached to all of this. Do you find that prevalent across Europe or in maybe certain regions?
I don't know if it's a regional observation. I would say that it is probably more unified around countries and cultures, in the sense that it is very much age-oriented, as it is called. But we have started sort of facing it already now. In discussions we have had with the societies as well as the clinicians, clinical teams, it's one of the major obstacles in designing the pilots. How are older adults, older patients going to be using technologies? And perhaps, they might not be able to, etc., etc. So we start facing this problem already.
Does anybody have any questions for Panos or Antonio?
There is one question in the chat.
Yes.
Leah is asking, quality of life depends on the life goals, the life goals, excuse me, patients have. Are those life goals taken into account? And we are running in parallel a second question on Mentimeter.
Yes, sure. I mean, if Panos, can I take this? Or yeah. So definitely there is some kind of profiling regarding the patients when we onboard them on the mobile app. So there is some kind of questionnaire, let's say, where we try to document the needs and the expectations of patients. So we take them into consideration in order to personalize the contents of the mobile app and the different, let's say, quality of life assessments that we try to perform.
Thank you. Does anybody have any questions specifically for Panos or Antonios in this specific area? One of the things that strike my mind is the barriers. Are you finding common barriers across all areas based on what you've heard today? If you listen to Meniere, the Meniere project, there was obviously barriers there. We talked to Gerd, who's no longer with us at this stage. She also mentioned there's an awful lot of barriers they're getting. Are you finding the common in the project you're getting common barriers across all projects at this stage?
Panos, do you want to take this or?
Yes, I think there are a lot of common things, and these are also appearing in the designs of the various apps and the dashboards taken already into account. Different groups, of course, have differences. Different cancer types have got differences to start with, but there are common things like, for example, if I can share with you the feeling of safety that you have to provide for in your technology application, it's a common thing. It's something that all patients share. I think all human subjects and humans share. I mean, if we would like to feel secure in our everyday life, and if this is promoted without participation in a trial or in a technology or in a whatever system later on, it will be taken seriously into account and will increase adherence, engagement, and stuff like that. That's one thing that we knew from previous studies, but it starts appearing in these pilots as well. Donis, if you want to add.
Yes. So regarding the barriers, I think that, for instance, education for healthcare professionals in order to better adapt to new technology outcomes should be also something that needs to be considered seriously in order to successfully implement technologies in clinical practice. So this is something that we have already discussed with our colleagues in International Society of Geriatric Oncology. And in order for us to make sure that technology is trusted and is used and adopted in day-to-day practice, we need to make sure that the new generation, let's say, of clinicians should be aware of the technologies and their potential. So that is my 2 cents in this discussion.
Absolutely, this is pivotal in the sense that there is a gap that we know that exists. There is a gap existing in the medical curricula, probably around the globe, with regards to education towards this end, especially with specific emphasis on technology and digital healthcare. It's a new thing, it's a new theme. The curricula are being modernized slowly but surely, but there is a gap now, especially if you consider those that are already practitioners. And this needs to be covered probably by scientific societies like CEU, for example.
Does anybody have any specific questions for Panos or Antonio at this stage? But I think there's something coming in here from the chat. Trust is real.
If I can use the chat question, Jane mentions about trust and how critical it is in the design and the engagement that they produce in these projects. And I think that's what I actually mentioned earlier on with regards to safety. I think it's the lack of trust is a barrier, and I was mentioning the safety sort of environment that something like this may create, a project like this may create for patients, will counteract with this barrier, which is the lack of trust, the sort of the phobia perhaps towards something new, etc. And we'll account for that. But thanks, Jane, for sharing with us this piece of work that you wrote. It looks very interesting, and we will certainly go through it.
Thanks, Jane, for that. Okay, so if we have no other questions, I think we'll press on. My thanks to Panos and Antonios. We're going to go to an open floor session. It was almost like a continuation. So what we did this morning is that slight hiccup in terms of the linkages, but when we got set up, we had the pleasure of listening to Georg Murphy, and she was very adamant about the impact of cancer in patients and well-being. And as we remember her saying, her background, she's a psycho-oncologist, and she brought the issues of barriers that were out there as well. And we mentioned a moment ago is stigma, and that was a problem we just discussed here a moment ago. And she also mentioned the fact that there seems to be an issue when it comes to standardization, distress screening, which I think was noteworthy of that area. And then one thing that she said is, and I think it's becoming a problem, is that there's a lack of resources, and she really believes that technology can help out here. I think she believed the fact that we can get early detection is very important, and that's where the AI technology and the work we're doing in big data and so forth can be very helpful. And that's the message I kind of take out from that, and also the importance of providing education, which came across very much so clear from what Antonios has been telling us in the live chats there, how critical it is to get education information out there as well. So if we can normalize the stress experience, and it will make the patient better, and that applies, I think, to all projects this morning. It definitely applies to what we heard in live chat, trying to get use the data to get the normalization, be that you're using a dashboard or an app and so forth, but you get it that way. So I think this is quite important. And likewise, from the NHAR project, we've learned quite a lot as well. I think the conversational technology has got a huge role to play going forward, and items such as chatbots and so forth can give us that. But we all have to understand the value of the data, the information that we're getting, and the sensors that we use. So I think the message I'm getting from this morning's session is that yes, technology going forward has got a huge role to play in the quality of life with mental health and cancer patients, and the fact that we're here today and trying to engage very much so with ourselves and also patients is kind of brings us to the foreground. And I think we're going to need a lot more of events like this to try to capture the information from the patient in a better situation. If we move forward, I think where we are at this moment of time is that we're going to go into an afternoon session. There's a couple of things I want to discuss with you just to progress where we are, and I'm going to bring you down to session 9. Session 9 will begin at I think 10 to 4 CET time. Now, what's happening here is that Panos, who is from the academic primary healthcare center in Sweden, will join us around that time, and we will have here a number of patients who will discuss issues that they've experienced, and what they will seek, and what we seek is dialogue. We will want to use the chat property that we're using at the moment to try to get in some questions from us who are attending. And then likewise, we will also present the projects that will be taking place tomorrow, so we can understand what they're trying to achieve and how they're going about it. There'll be small presentations, and once that is done, then we're going to open up the questions that from all the projects have, and get an open dialogue question going on here, which Panos will moderate over the period of time. So I think we're going to find that absolutely more challenging, because most people are not comfortable with chat in terms of these kind of events. But here we go for quite the opposite situation. We're going to have dialogue, and I'm going to encourage that. So that will take place at the afternoon at 10 to 4 CET time. So in the afternoon session, we're going to talk to Sartoris, who will explain the oncology project, and this has been going on for about 18 months now, if I'm correct. And so we will understand the importance of what that project is trying to achieve. And we then move to the second project, and this is the FATE project. And this is a project that looks very much so at using federated learning and identify the depression markers. And this is Gary with colleagues, Seni and also Stefanos will also present in terms of what's going on in terms of clinical trials, and also in terms of the demo which is going on. Then we go to persist, and I'm looking forward to this, because Victoria and Gashir will present. Initially, Gashir will give a demonstration, and also we'll be supported by Victoria on the overall project, and the importance of the ecosystem. It's going to become very relevant to everybody there, and that there in the afternoon. Finally, we're going to go to the Quality Top project before we get to the round table. And the Quality Top project is also, they're very much so focused on the CAR-T2 cells and leukemia. So we will understand how they're applying big data and AI and simulation models to gather the analysis. So collectively as a unit, there's an awful lot of kind of cross-fertilization ongoing. So today's event helps us to kind of see where commonality exists and how we can build on that. And I'm very grateful for everybody who's been able to attend this morning session. Again, please accept our apology for the slight cock up in the technology this morning, but I think we're fine now at this stage, and we'll press on. So let's just give us an update on where we are from this morning and going forward to this afternoon session. Is there any questions from anybody at this stage? Okay, so okay, we're good. Okay, so what I'm suggesting that we do, it's been a kind of an interesting morning. I'm grateful for everybody who presented this morning, and those who could join us this afternoon, please do. We'll go on to move to these projects starting at Conor Relief. So I suggest we get back at 1:30. We'll all come alive at 1:30 at CET time, and then we'll go through the schedule that's there for this afternoon. So thank you all. I'll see you again later on. Bye for now.
Bye.
See you later.
Visitors. We begin in about 2 minutes' time and let people come through after the lunch break. Good afternoon, everybody, and welcome back again for this afternoon session of the Meeting Minds 4. We have an event today which covers quite a lot of the cluster projects, and the whole purpose of the event is really to get feedback from many of us at the meeting today and get ideally customer and caregiver feedback. So our projects today in the afternoon will be on Connor Leaf. So Taurus is ready for this. We move to Fate. Then we move to Resist, and then we move to Quality Top. They're the four projects we're going to be looking at this afternoon. And finally, we're going to hold a roundtable session, which panelists will join us later on. So the O'Connor Relief project is very much so a project which was here from the beginning when we got together with Meniere to make it happen. And what they're doing is that they're asking the quality of life in cancer survivor. Can we measure it? Can we improve it? Satoris is leading this project. He's the project coordinator for the project, and he's a research innovation manager at Exus. Satoris, I give the floor to you.
Thank you, Tom. Thank you for the introduction. Let me share my screen, which should be this one, and you will be able to see that now without. Do you also see this one?
Yes,
yeah.
We see it.
Okay, perfect. Now let me find the screen here. Okay. So yeah, first, the title of the presentation is Quality of Life in Cancer Survivors. Can we measure it and improve it rather than approve it? That was mistakenly written in the agenda. But now that I go again through it, maybe the approval of what we are doing in a clinical setting is also a factor that should be considered in this kind of projects. So yeah. This is a major part of what we're doing in the OncoRelief project. OncoRelief coming from oncology and relief, which is quality of life in cancer survivors. Can we measure it and improve it? Let me move into the next slides. So why should we really care about it? Why quality of life is an important parameter to take into account? Well, first, it can be a determinant and the predictor of post-treatment health status, meaning that we can see how cancer survivors are doing and potentially identify issues that may come up in the future. And also, it's a very useful metric by itself because everybody wants actually to have a better quality of life and better health outcomes of any treatment or post-treatment situation. So this is something that we should care about. Now, what we expect, what are the determinants of quality of life? What affects it really? We have identified that doesn't need so much research in order to identify what is important there. It's sleep quality, movement, whether you can move or how much you can move, or what kind of difficulties you have in moving, weight, and what these may, what other impacts weight has, pain, different levels of pain or distress, fatigue, anxiety, and potentially other issues and other factors that may affect how well a person feels, and specifically a cancer survivor feels. So it is quite apparent, and we have already, this has also been mentioned in the previous presentation by Andonis and Panayotis. It's not something that can be defined in the same way for everybody. We need to personalize this for each one of us or each one of people that have been surviving cancer treatment. So this is something that needs to be taken into account. And also, we care both for the absolute values, meaning that it provides us with some information to know that this person has an X quality of life index and somebody else has higher quality of life or lower. But also we really care about the trends or changes of what is happening in a longitudinal study, let's say. So we care about both of these issues. But in order to actually do something about it, we need to quantify it and measure it, meaning that in order to be able to improve something, you need to be able to measure it. In order you need to have something like a way to quantify it, right? So what we have discussed within the OncoRelief project and what we have been doing is to include 3 different types of data that can be used. These are wearable sensors. These are also questionnaires and questions being responded within validated questionnaires, and also medical records that are available in the hospital clinics that are within the consortium of the project. So we believe that using these 3 types of data, we can grasp or we can use an index that is a proxy for how well a person feels. So going through each one of these components, first we have developed the OncoRelief SmartCo wearable, which is, let me go, I think if here this goes through the screen, it should be fine. It measures different parameters such as heart rate, oxygen saturation, temperature, motion, air quality, heart rate variability, which is a proxy for stress, respiratory rate, sleep quality. Some of them may be, at a first glance, may be relevant, but it may, if by using all this data, and we may be able to find correlations. For example, temperature may be relevant here, but yeah, if temperature plays a role on how well somebody feels, and especially if there are other issues related to movement patterns, etc., then we may be able to find something here. Moving on, sorry. Yeah, the other thing that we have developed is the Guardian Angel mobile application, which plays actually two roles. The one is that it provides the interface via which the wearable sensor is transmitting data back to the cloud, but it also is a really critical part of the project because it is the interface that the cancer survivor has in order to interact with everything. So let me start playing that. It comes with the questionnaires that are being transmitted by the system, validated questionnaires that provide specific questions related to needs that have been identified or symptoms that have been identified. It also provides the viewer with data charts based on data that are being captured through the wearable sensor, and also is the portal for the notifications that come when a new questionnaire is becoming available for the patient, or a new suggestion, a new intervention provided by the clinician is provided. Let me, I think that you can see also the way, for example, that the person using the application can respond to validated questionnaires, which are then taken into account, and I will explain how, in the quantification of the quality of life index. Let me go to the next slide. So yeah, the other type of data was the medical records that are being also incorporated within the application within the AI engine. So essentially, we have defined within the project the quality of life index as the average of specific categories, where each category is how close or how far the patient feels with regard to specific needs or symptoms. So this actually comes from, in real time, from two, again, as I mentioned earlier, two main sources. The one is the responses to questionnaires, where this comes once per month, but we consider that as not really granular, because we would like to have more information coming more frequently. So we complement that with data from wearables when this is applicable. So the idea is that we have both vital signs and biosignals, and also information coming through the Guardian Angel application. These are all processed in the back end, in the OncoRelief AI engine in the backend, and then specific after AI-based analytics, we have the suggestions for interventions to the healthcare professional, and upon confirmation by the healthcare professional, these are being sent back to the patient or the cancer survivor. And in order to facilitate this process in the side of the healthcare professionals, we have developed also the web application included in this. This should not have video and this not give audio of me. Let me try it again. Yeah. So where each healthcare professional is able to go through the patients that he or she is supporting, and see the responses to questionnaires, see also the quality of life as it is calculated by the system, and also the predicted values in the immediate future. See certain details about the patient, go through the biosignals or other information that is being captured by both the Guardian Angel application and the wearable sensors. See, again, as I mentioned, the responses to questionnaires, which questionnaires have been answered, which have been not. And also at the end, go through the suggested, the recommended suggestions that have been provided by the system based on the quality of life and the specific responses to questionnaires, and the specific biosignals coming from the wearable sensor, and come back. And these recommendations are being approved and are being sent back to the patient. So I think this more or less concludes my presentation. Let me go to the last slide. We have completed the development of the technical stuff of the project, and we are now in the training phase, and we are really ready to begin with the clinical trials that will start in early March, so that we'll be able to validate and have many of these aspects being approved, as the erroneous title of the presentation was, and finally improve the quality of life of cancer survivors via these tools and AI. So thank you very much.
Thom, thank you very, very much. A very detailed, clear explanation. I love the presentation that you gave. It gave a clear insight on how you're doing things, and warmly appreciate it. Some thoughts come to my head was in terms of benchmarking. Is there a method that you apply at the beginning to determine the benchmark for the individual patient? Is it like some kind of customization mechanism you're using? And then over time, is there a time where you readjust the patient and see, should we change it around? Or is there some kind of back-end thing working there handling that?
Well, this is an interesting point, and thanks for raising up. I don't know if it's you, Tom, or another question, because another person asking that, because I cannot see the chat section. So the interesting thing is that we need to have some firm, some things that could be flexible, cannot be so much flexible during the clinical trial itself, because you need there to define specifically what the quality of life index is, and we have defined that in a clear way, in a mathematical way that is there. But what we have not been able to do within the ethical committee for the clinical trials is to make this a little bit more dynamic, make it more adaptable to each patient needs, or maybe change it depending on different situations or different things. But what we have done in the project is to actually create a dual timeline where for the clinical trials, we have a certain set of solutions, a certain set of developments that support the clinical trials as we have described them, but also in the meantime, and that's the second branch of development, we are doing more things that will be provided at the end of the project, including more adjustable, more adaptable, more dynamic calculation of the index, more different things in terms of the framework for the recommendations. So it will be something like two branches, the clinical trial one, and the more experimental and the more research related branch.
Eric from this morning mentioned the fact about geographically where people are and all kind of ethnic background. Do you make any adjustments based on the person's geographical basis in order to determine what the index should be?
Well, again, this is something that we are considering, and we are doing that in the experimental part, but we are not doing that in the clinical trial part. So in the clinical trial, we have the same questionnaires which are validated in both countries, both Germany and Italy. These are the two the clinical sites that we have on board in the project. But yeah, the socioeconomic factors affecting differently different people in different countries and different areas across Europe. This is something that we are taken into account in the experimental branch of the project.
Even religion will have an impact on how you adjust things depending on how you do things here. I think there's a lot of talk on that one. The last step before I'll move on to some questions coming in on the chat. But what I'm thinking about is how do you get feedback? Do you get feedback on a daily basis, or weekly basis, or a monthly? How do you handle it? Do you do it on a per person basis?
In terms of data capturing and data, I mean, this kind of detailing, this comes 24/7. I mean, this comes not we capture data 24/7, but every day there is a sync from the wearable and the device back to the cloud engine and processing it. So then results may be coming whenever a notification comes to this is another thing that in order to avoid overloading the healthcare professionals, we have developed a system where not always a notification passes through them when there is a significant change, where something needs to be noticed. No, I mean, because you may expect that for some time nothing changes, situation is normal, fine, so nothing goes there. But whenever we identify a significant change, then a notification comes up to the healthcare professional, and he or she can act upon it and do something. So yeah, this is not, I mean, there is no specific frequency for that.
No, I understand. Thank you very much, Satoris. There is one question coming to chat. Do you mind this story if I take it? It's it's coming from Leland Rye, right? And he's asking, who is the owner of the data? Is it the patient?
Yeah. So this is something that we have taken into account. Is that that's why we're also including our own device, the device that we're developing, so that we do not move data to Google or Apple or anybody else. It's data that are being stored in OncoRelief servers, the owner is the patient, who is always able to ask for the deletion of data or anything to do with the data, can download them all in their own storage sites and everything. So if that responds to the question, I think, yeah, or if this clarifies the situation.
Okay, so maybe I can share the poll questions for OncoRelief.
I'm stop sharing my screen.
Yes, let me share it here. So you should be able to see the poll. And both using the access that it's shown on the slide.
If I may to provide some background here or some context, is that there is a discussion on whether patients need or want to view details on what data, on the type of data that are captured, meaning such as heart rate or stress, or the other view says that maybe this creates more stress, or this is maybe not something that they would like to see, and they would just would like to see the recommendations or the questionnaires that are to be responded. So that's the point here. And if there is any thoughts, I mean, on that.
Yes, my thoughts are perhaps this question we can bring towards the roundtable session, because I think we'll have patients specifically around there, and this question you're raising is very prevalent to that area. So may I suggest we move to the next question?
Yeah, this is the next one.
I'll ask everybody who's listening in at this stage. I know some people hate doing this, but it does help us. So if we get some feedback at this stage, it will be very encouraging, because we will analyze the feedback we're getting. So if you don't mind doing this, you are helping us, and I think I'd ask you if you could please just get onto the Meniere.com or on YouTube, use the code to get at it and give us some feedback. So we leave it a while. I know we've only got 2 at the moment, 3 and rising, but the more we get, I think the better. And
I've reshared the link in the chat in case.
Yes, please. This will help. This will help. I won't fill it in because I'm a bit biased, but anybody who can fill it in, please do. It does actually help us. I know you might think it doesn't, but it actually does. So we're going to try to move forward with that going forward. Okay, so we leave it at that stage. We got 3 at this stage. So thank you all for that. Is there any other questions that we have for the floor at this stage that anybody would like to raise for Satoris? Okay, then the famous expression, silence is golden. We'll go with that. We'll move on forward to our next presentation. Our next presentation is a project I'm involved in called Fate, and it was through the project Fate that the whole concept of bringing this cluster together became real. And Satoris is one of the early people that I spoke to. Thank you again, Satoris, and Meniere. So what we're going to do now is try to talk on the Fate project. What Fate is all about is trying to come up with depression markers, and is using federal learning, artificial intelligence as the means to do that. And it looks very much so at breast and lung cancer. So we'll have 3 people talking at this presentation. This will be Gary, Seni, and also Stefano. So I'll give the floor to Gary.
Okay, guys, just share my screen here. So Meniere, can you let me, I think you're still in charge. Start share. Okay, thanks Tom for the introduction, and thanks for the team for arranging this event. I think it's been a very interesting morning so far. You can see a lot of common areas that the projects are working with, so it's good to get different views on what we're doing. So the FAITH project, what it's about, it's a federated artificial intelligence solution for monitoring mental health status after cancer treatment. So the important words really for us are federated artificial intelligence, after cancer treatment, and monitoring mental health. So, just a second, I think you covered up here. Cancer patients face several challenges which affect their mental health. This then leads to anxiety, it leads to depression, and it worsens the quality of life. So there's an incidence of 18 million new cases of cancer per year, and then this affects depression. Then will affect 15 to 25% of these cancer patients. As the population of the world is increasing, we're all getting older, and as medical science is improving, we're facing with a rising occurrences of cancer. So more people are surviving after cancer treatment, and this can lead to an impression of their self-perceived quality of life can be affected. They can feel feelings of anxiety, of depression once cancer treatment has completed. I guess these feelings happen during cancer treatment, and everyone thinks, okay, once the treatment is finished, everything is good, we can move on. But it's actually not the case. And this is what we're trying to look at in the FAITH project. So it's this consequence of anxiety and depression that we're addressing. So we're looking at an AI-based technology to track depression markers. What we've targeted in this project are activity, sleep, nutrition, and general outlook. We're tracking the general outlook through voice, similar to the Meniere project. We're trying to monitor these downward trajectories, looking to see when, say, these depression markers are starting to fall, and then ultimately inform the point of care of these declines. By doing this, we're going to help cancer survivors to improve their quality of life and get early detection on what's actually happening. So we've a strong multidisciplinary team in the consortium. We're working from 5 countries: Ireland, Portugal, Spain, Italy, and Cyprus. And we've got 3 hospitals, a number of technology providers, research centres, and SMEs. So the consortium then, ourselves, Waterford Institute of Technology, we're the project coordinator. We've the Polytechnic in Madrid, University Polytechnic Madrid, the LifeStack team there. They're helping us with the system architecture, and they're also running the pilot trials. And you'll hear from Zeni later on in this presentation about how the trials are set up. We have Uninova from Lisbon. They're looking at the technology. They're looking at the sleep trackers in the project, and also with regards to technology transfer into business. We've 3 hospitals in the consortium. We've Champollion Foundation in Lisbon, we've the Gregoria Marinon Hospital in Madrid, and UPMC in Watford. And what we've done in the consortium is we've got 3 pairings. So we've paired each hospital with a research centre. So UPMC is linked into Watford, Gregoria Marinon are linked into UPM, and Champollion are linked into Uninova in Lisbon. And then we're also supported by 3 SMEs in the project. Deep Blue have played an important role in gathering the requirements and having co-creation workshops, and they're also in charge of the dissemination of the project. With Suite 5, who are developing the app, who are involved in integrating the different modules from the app, but also looking at exploitation paths from the project beyond its lifetime. And then we've TFC, who's led by Tom Flynn, and you can see the work that Tom has done. He's looking after standardization, quality management, and communication and exploitation. And as part of his role, he's brought this cluster together and is running this event. We also have an advisory board. You would have seen Jane Walsh this morning interacting with us. She's played an important role in this advisory board. We also have Federica Facciota and Mark Sujan. So we meet with them, bring a project to them, see what we're doing. They can see what we're doing and advise us on the progress we're making. So what are the main objectives we're looking to do in FAITH? We're looking to develop the FAITH app module, which, as I said, has 4 main areas: sleep, activity, nutrition, and voice. And we're tracking through the device-based behavior on our app. We also have validated questionnaires that are imported into the app, and then we also have trial follow-ups. As mentioned, we're going to have 3 trials, 3 observational trials in the 3 hospitals in Ireland, Portugal, and Spain, and to capture the prospective data that can help us build the predictive models. And then an important part of faith is developing the federated approach. So it's important that we keep the data at the edge and the users. So in the first version of our app, we're going to be used for collecting data so we can actually build the models. And then the second version, it will be the federated AI app where the models are moved from the cloud and moved closer to the device. So we're going to demonstrate applicability, usability, effectiveness, and value for faith concept models, techniques, and framework in a real-world situation. So developing the app, capturing the data, and then moving to build models and moving the models to the edge, and then proving this in a real-world situations. This is the real kind of crux of what we're trying to do in faith. So the faith ecosystem, we have the patient who's going to provide the input to the faith app through the data that they provide. We have a team of healthcare professionals revolving around the patient. They're going to help. First of all, we're capturing data from the hospitals themselves, but then also advising of what needs to be done when certain alarms are raised. With data scientists that are building the models and the federated learning approach to AI for gathering the data and monitoring at the edge. So faith, as I said, is relying on a federated approach. So traditionally, data would be collected and sent to the cloud. So as I said, we're collecting sleep, activity, outlook, and appetite data. This would have been sent to the cloud and analyzed in the cloud. We're trying to move away from that approach where the models are initially built in the cloud, but then they're sent back down to the devices, and the analysis can actually happen at the device. So we're keeping the data that the users have generated close to themselves, and we're not sending data around the place, which is improving their privacy. So when a negative forecast on the patient's mental health is detected, what do? We raise an alert and it's sent to the healthcare providers, and they then decide whether it's necessary to bring in the users themselves. There's still a possibility of contacting the users, but we're still investigating this within the Faith project. Some of the major challenges that we're facing in Faith. So first of all is identifying the right indicators. So we've targeted activity, sleep, nutrition, and outlook. And from this, we're going to build the prediction models. We're tackling privacy issues, and to address this, we're implementing the federated learning approach. And as I said, it means that the data stays on the mobile phone for the user and is not sent into the cloud, and it's just the models that are circulated between the user's device and the cloud. As mentioned this morning, a big part to play is trust, and as part of our project, we're looking at explainable AI, where when reasons or alerts are sent into the healthcare providers, there's always a reason given behind the decisions that the AI has made, and it's moving away from the black box approach. So we're supporting the clinicians as opposed to taking the place of the clinician. So when the clinicians get the data, they can revisit, see what's happening, we explain what's happening, and they can validate if the decisions the devices or by our system are true or make corrections. Also engaging with users. We've had a co-creation approach at the start of the project, and this will continue through the project. Once we move to trials, we'll trial with a subset of users first and then move to larger trials so that the users are constantly engaged and feeding back to what we're doing. So the overarching goal for Faith is to build a better model for mental health monitoring. And to achieve this, we've broken it down into three smaller objectives. As I said, the first one is the federated AI solution, using prediction models at the edge. The second is the clinical validation of our tools. So through the trials, we'll be clinically validating what we've actually developed and the models, and then fostering awareness for mental health status in cancer patients and their doctors. So once the Faith concept has been prototyped, we'll go to real-life solutions. When the patient is finished with their treatment, we've targeted a 5-year span. then they can be involved in the faith trials. When they finish their treatment then and 5 years have passed and they're getting involved, they'll get 2 devices, or they'll get at least they'll get the Faith mobile app and they'll get a tracker device. And then we're tracking the 4 markers. 2 are going to be interactive, which is the appetite and the outlook, which will be done through questionnaires and a voice analysis. And then we'll have passive collection as well through the sleep and the activity trackers. This combined with the questionnaires that we use will give us the clinical assessment of the patient. So what I'm going to do next is move over to Stefanos, who can give a talk on the device itself, and he'll walk through the use of the app. So Stefanos, I'm starting the player now.
Yes, hello. This is actually, I don't see it on my screen. I don't know why it's frozen or if it's just me. So supposedly the video is already playing.
It froze my end.
Yeah, this is a quick 5-minute video demonstration walkthrough of the mobile app as it is today with the help of a video. So we have to sync this a bit.
Can you see it now? Is it playing?
No.
Okay. Can you see the video itself? No. Stefanos,
No, we just see the...
It might work if you try sharing from yours. Hold on. Let's see. Hold on. If I can just give it a second. Start share. Okay.
Yeah, we can see it now.
Can you see now? Okay.
Yes. So let's start again the video.
Okay, I'm starting it now.
Yeah, I've seen the timer. Thanks. So this is, as we said, an effort on our side to give a 5-minute video walkthrough of the mobile app as it is today. The goal of this app is to capture, as we said, activity, sleep and nutrition data from the user. Right now, it is used in the first stage of the trials as at this role, but it aspires to evolve and to support the employment of the federated AI. Parts of the data, for example, the daily steps or daily hours of sleep, are collected in an automated way without user interaction. Other parts, the questionnaires, we ask the input directly from the user in predefined time intervals. Here you can see in the dashboard forms to collect the data related to nutrition, then the questionnaire section, those which are open for reply, and finally the activity and the sleep data already collected for a certain date. Sleep data include the total duration of sleep, as well as the sleep phases, deep sleep, light sleep, and REM sleep, and the awake time. So this is what we collect here. Now we go back, the activity data for a certain day, again, include the number of active calories, the number of steps taken, and the total length of distance covered. Active calories as opposed to total calories, because the total calories is passive plus active for a given date. Activity and sleep data in the context of the app can be also presented aggregated in a weekly view. Steps and sleep per day, as well as in a monthly view. Steps and sleep per week. In the example here, it was created a couple of weeks ago. We have the week of 13-19 February, or alternatively the month of February as a whole. Activity and sleep data, as we explained, are collected on a daily basis passively, as opposed to the data collected actively via questionnaires, which we will show next. So we will go back to the dashboard and we will see questionnaires. Some of them come forward every week. This depends on how they have been defined by the clinical partners in the project, like the sleep quality questionnaire. Here I fill one example reply. There are other questionnaires which come forward every month, like the Hamilton Anxiety Depression Scale, which the user must fill in within a predefined time frame from when they received it and send it. Now this is also a quick demo. I start filling in this HADS questionnaire. I want to show in this demo that I can navigate back to the dashboard at some point. As long as the time is not up, I can close the app and reopen it on the next day. I can go back to the HADS questionnaire and continue with the reply from where I left off. Now, depending on the needs coming to the project from the technical partners, some questionnaires could come forward every 3 months or at the start and end of the trials period. Now, an open issue in general, what I wanted to give as a key takeaway to the audience with this kind of data capturing or so-called tracker apps, especially when it comes to data we ask to capture directly from the user, is the retention of the interaction over several weeks or months. Users, we expect them to, we believe that they could easily grow frustrated or bored of filling in the same questionnaire over and over. For this, we rely on 2 things: engaging user interface that we have designed with the help of experts, as well as the interest of the users to participate because they perceive the value of the research outcome. Development of the Faith mobile app is still ongoing. I showed there that the next steps we have now is the creation of the profile page and the calendar view. This was the last 2 frames of my video. And as I said before, this is what we call the first version, in the sense that the second version should also include all the federated AI module that will transfer knowledge coming from the collected intelligence back to the user of the mobile app itself. This was Stefanos Venios of Suite 5 Data Intelligence Solutions, which is a partner of the Faith project.
Thank you, Stefanos. I'm going to introduce Xenia next to present the work we're doing on the trials in the project.
Mm-hmm. Are you sharing, Gary, or?
I'll share my screen here now, yeah. 2 seconds.
So, hello, everybody. Good afternoon. I'm Xenia Beltran from Universidad Politécnica de Madrid. Okay, I'm from Life Tech in department in the Polytechnical University of Madrid, and we are leading the part of, together with the hospitals, okay, all the area of the trial. Next, please. Okay, so our approach in Faith, okay, goes, and the trial goes coupled with the technical developments that you have seen before and explained by Gary and by Stefanos. If we want to split a little bit our approach, okay, even technically, we can say that we have 3 phases. The first one was the requirements. The second one, as explained by Gary, the second one is what we call the alpha applications, okay, which is the application that you just saw from Stefanos. That's the current development and our current status right now, together, okay, with a backend for the point of care to support the trial. And this first phase of the application, okay, is the aim is to really allow the capturing of the data of the trial, as our study is prospective. So we are using the data for modeling, okay, that is gathered in the trial study. For this, we are creating this repository, as Gary said, that is a private cloud, okay, and is for sharing and doing the analytics. While we're doing the study here and we're developing the trial and capturing data, okay, our study will allow okay, to start with analytics and modeling and evolve this application to the next applications, which will be the final application in faith, which is the federated application. It will rely on federated learning, and actually the approach, it will be taking directly data from the phones, okay, in a secure manner, okay, and be able to have the model to fly, okay, over the different points that provide data to the application and to the models as such. So next slide, please. As commented, we're working with prospective data. So our trial is a multi-center, prospective, and observational trial, let's say it that way. For this, we have done several things. Among those, okay, we are working with a statistical plan, and this statistical plan supports two things. One is the sample calculation, and for the sample, due to the COVID and to avoid issues, we have done two plans, plan A and B, to have a backup, okay? And the plan B, which is the last one we want to work, it provides the minimum sample that it has been fully calculated to generate the federated models. Our ideal is, and we aim to reach, okay, the 300 patients, okay, through all the centers that are the 3 centers explained by Gary in Portugal, Madrid, and Ireland. In this sense, okay, as for the alpha stage and alpha application, okay, we're working with this private cloud. Everything is anonymized, and we're working not only with anonymous data for doing the modeling of the future federated application, but also we're using all the masking approaches needed, okay, not only for allowing privacy, but also avoid bias, okay, in all the generation of the models as such. So we're in, we have a circle because this is our current state, okay. We are processing, we are going through ethical committees. Most of the protocols have been approved in all the centers. Actually, our applications are almost also ready to be applied. So next, please. This is a picture that really illustrates our approach right now. So actually we have a backend, okay, with a web tool at the hospitals and points of care, which will support not only the alerts, okay, but also generate the agendas for the trials, and that support the system in the applications of the patients, which you can see in the right-hand side of the slide, okay. It allows the CRF collection and clinical data collection also that is going to be used, as well as also collects all the patient reported outcomes, okay, of all the questionnaires. We're using standardized and validated questionnaires, validated in all the countries. So actually to have not only a standardized manner to compare data later, but also, okay, known that all these tools will avoid a part of the bias and have been fully tested in all the countries as such. So everything is supported by the data infrastructure, as commented in the cloud, that not only has the repositories that handle in a private manner all the data, but also it has the APIs that support the services that really enable secure transference from the applications to the cloud, and to the cloud, from the cloud to the application as such. And the data infrastructure that is in the application, as commented, okay, we mostly, as commented by Stefano, is in the background of the patient. So everything that goes with the models of sleeps and activity is not felt or really need to be fully tracked by the patient, but only we have the intervention regarding the questionnaires that need to be filled, and some of the nutrition issues or voice approach and data collection that we need from them. So next, please. This is a representation on how our trial goes. So actually we have the calendar that is driven by the protocol, and actually all this has been integrated in the Faith app as an agenda and actually using quite a very patient-oriented and user manner. In the back, okay, we have the Fitbit and everything. Even data for the Fitbit has been pseudo-anonymized, so actually we ensure that the data that will go and is used, okay, is not even identify the patient at that point. and the data coming from the hospital, that it will be in the cloud. And then, okay, when we put it together, then we'll be doing the model. Next, please. As for our trial, I want to say that what we aim is to have this continuous monitoring of the daily activities in sleep, voice, activity as such, and nutrition. Those are our models. And actually, we are doing is that with the statistical plan, okay, we have put together the tools, okay, for doing the predictions or how these parameters, let's say that way, okay, can predict, okay, the depressive symptoms when we compare with the depression questionnaires, which we're using the HAM-D and the HATS as such. To this, we are doing this statistical processing, and we have generated already a data model. Our data model is FHIR-based, okay, and the data model is also what we are starting to initiate, to evolve, okay, for supporting the federated application in the next step. We also are working not only with the missing values, okay, our statistical plan also has all the sizing adjustments that we foreseen for having the plan A and B. And also, which is very important for us, have intermediate analysis that really allows us to build the federated application while we are going with the trial as such. Also to say, next please, that if we want to summarize at the end, what we can say is that what we are doing, what we want really is to bring the attention of the healthcare services and the point of care and people, that is cancer survivors as such, okay, when the depression markers show sign, okay, when we want to do it as early as possible, as soon as they start. For what? We really want to downward the trajectories of depression, okay? We really aim to identify the trends, okay, with the areas and models that we are building and how they can affect not only the depression, but the quality of life. And our how is the faith application, which is provided this federated artificial intelligence post-cancer support, okay, that using the app provides easy and provides an easy way and an easy tool to be used by cancer survivors, okay, to really have this depression early diagnosed in a predictive manner. So with this, okay, we think we have mostly summarized, okay, the project. Thanks, Gary and Stefanos, for all the previous presentations that support ours. Well, the floor is yours, Tom. So thank you. We go for questions.
Thanks, Enia and Stefanos. I think we also have Philip here, who is the technical manager for the project.
Okay, I'll take it before if it's okay with anybody. Gary, Stefanos, Seni, as ever, thank you all very much, and Philip, of course. We don't have any specific questions in the chat, but what I'd like to do is ask about, we're going to go in FATE project, we're heading towards the clinical trials. And I'm asking this question to everybody involved at the event, but also those involved in the project we've seen beforehand. What are the main issues when it comes to clinical trial that you're experiencing, or what are the barriers that you're seeing at this moment of time? Because the more we can share knowledge and understanding, the better we can prepare going forward. So I'd like to just put that on the floor. Is there any advice there for us on how we can prepare better for our clinical trials?
Do you want me to get it?
Go ahead, Seni. I can't hear you.
Do you want me to get it? To get the question? To answer?
Sure. Go ahead, Seni.
Okay. I think there are several things, okay, that are barriers, okay, because right now, I mean, COVID has been for sure a big issue, okay. We started the project and we mainly have worked during the last years, okay, with the COVID issue. So actually, people and cancer survivors that are which their health, okay, status is good, it's healthy, let's say that way. They usually don't go to the medical appointments, so it's quite difficult sometimes to keep the follow-ups and actually the contact. Okay, so actually the recruitment is hard, and I think it's an issue that also could be for many other areas or for any clinical trial as such. The good thing is that many of these clinical trials, and we have got an experience of how remote clinical trials are working. Actually, what we are supporting right now with all these devices is this part of these remote clinical trials. So we expect that also there is a higher adoption than before, okay, or than even when we started the project. The people have these applications to be used, okay, and to really connect in a remote manner, in a more trusted manner than before. But it's for sure that unethical committees are also, with the new regulation of the GDPR and privacy, are getting also much more strict. So actually all we want to present, and we have to present several times, the protocol to ensure that actually we're first fully patient oriented, second that we have all the APIs and GDPR regulation compliance, and third, that if we are doing things like, for example, for artificial intelligence, data transfer agreements agrees with confidentiality and privacy from all the partners for processing the data, and for data providers and for data processors as such. So I think altogether it puts some barrier, but I mean, we're happy to go through them and work with them, because it's part of the big experience that faith is giving to all of us.
Thanks for that. I kind of get it, but my worry too going forward is that we lose patients in the process. I don't mean from mortality reasons, but because they drop out. I think that's the word we can use. Victoria, would you mind coming in here? Victor, what are your thoughts on this? How not to lose patients? Do you have any thoughts on that one there?
Hi, Tom. Let me share my image. Can you hear me?
Yes, perfectly well.
Yeah. Well, I think that regarding this question in Persist, we faced some problems because we ran the clinical study right now for a year. So patients started to get a bit tired of wearing bracelets even in summer, so they wanted to go to the beach, and these kind of things that pose a burden for them, made them to start to think of leaving the study. So for us, this was a very hard time for clinical partners. They have to make a big effort to keep the follow-up with patients, phoning them, encouraging to keep working with us, and explaining them that their data was really important for the research. So in the end, and I think that this is a big work for clinical partners, and they make a big effort to keep these patients into our study. I think that we have to thank these clinical partners for keeping these patients in the study, because we face these kind of problems.
Yes, it's a constant worry, and someone's coming his way. What I'm worried about is that it's maybe it's just an idea. I throw it out there. Is there a way to incentivize patients to stay in the trial? Because clearly it's an effort to bring some patients in. I understand. Senny was very clear how that happens, and if you lose them, it's almost repeating it. And if you had difficulty initially, then the more the drop out, the more the difficulty. So it's not like replace one-on-one. I think there's more effort to get more in second time around. So is there any way? I don't know. Maybe Antonio, you can come into this conversation too. Is there any way to incentivize people to stay in the trial? Is there something that can be done, or have you any knowledge or understanding how this was achieved? Antonio, could you come into this conversation? Is this possible?
Tom, I guess just Gary here. I think that's one of the things that Stefanos actually raised, is say when we're going back to the users or the patients repeatedly with questionnaires and questions, it's trying to keep them engaged and trying to appeal to, I guess, to their good nature, that they're helping people going forward. I don't think we can give monetary or material rewards, but it's appealing to the type of person that will actually get involved with these trials.
Let me try and ask, if we can't incentivize them, is there something like more visits to them, or more direct engagement, or like more weekly meetings, or something like that? Would this work? Because I have this fear that under assisting where we were because of the lockdowns and all this kind of difficulty we've gone through, that over this specific period of time, people will not be as enthusiastic of being involved, and therefore how do we make sure that we don't lose them? And that's one of worry. Antonius, welcome. I'm just curious, what happened in live chat? Do you have any incentivification method, or do you have any kind of way to keeping people in board on during the trial so we don't lose them? Have you any experience that way?
Well, one strategy that we try to follow is that, as we described in our presentation, our aim is that by day one, we include patients, and we keep following up with them in different activities that we try to involve them. The design of the application, the data collection studies, again with feedback, etc. So this way we try to build trust with them, and we try to keep them engaged throughout the project, and even create a team, let's say, of patient experts that will be also ambassadors for bringing into our studies other people as well. And we also try to be engaged with patient associations. Patient associations play a key role into asking patients to be involved in different activities, even into research. So I think this is key to find people that could also act. I mean, we have the technology, but we also need a human factor to help us to drive the implementation of the research. Otherwise, technology on its own, it's difficult to be implemented. We need also to have a human factor as an intermediary to deliver the technology.
Okay. Thanks everybody for having that kind of conversation. Pretty good. Now, in terms of time, we're doing our best we can to keep to the time. We're going to head into another short little tea coffee break. I call it tea coffee break, but the whole idea is that you can drop out for 10 minutes and then check any emails, whatever you want to do, and then we come back on again. So if we can just go to the next session. Sarita, can you please put up the next slide? And again, thanks you all for this conversation. Gary, Stefanos.
So shall I show the poll for Faith, or shall we move to?
Oh, do we have? Absolutely, please do.
Okay. Let me just share it. Okay.
So here we have the poll. Do you see faith type trackers as something that you would use? And then we have 5 options down here. I have never used a tracker app and I would not use one is one. Another answer is I have never used a tracker app, but could see myself using the Faith app. Please, while I'm reading, vote as you see appropriate. I use a tracker only for exercise tracking, but would not go beyond that. The 4th one is that I use a tracker only for exercise tracking, but would expand to capture more than exercise to use the app. And the final ones, I regularly use a tracker and more than experience that and would use the Faith app. So these are the 5 suggestions towards you. Please give us some feedback. The more feedback we get, the more we will help us with it, our track. You know the methodology. The link is there on the app. You can just go into. So I did this for everybody else. And then we've got to move it to, you can also go use the code there on the YouTube. So you've got some options. We keep it open for a little while and then we go to the second question. Oh, sorry that my questionnaire doesn't work, doesn't refresh.
No, I'm the same. I guess this question really was going with the premise that there would have been a lot of patients involved in the event today, and it was trying to gauge whether people are inclined to use this for I guess, exercise only, or go beyond and start using these type of trackers for health?
Okay, I think we're having trouble with the tracker at the poll questions. So I suggest rather than do it now, we'll go take a look at the second question, see what it was. But I don't think
I think we need to use different code for the Mentimeter. I mean, this one is a new code.
Okay.
Can you share the code in the chat, please, Zoraida?
Yeah, I think it's shown in the slide.
Yes.
If you
okay, now it works. Now it works.
If you go to menti.com and then check, I will change the code in the chat. Yes.
Yeah, exactly.
If you go to menti.com and use the code that is shown in the slide, that also should work. I will copy the link.
Yes, please. Okay, give it a little bit longer as we're getting in there now. And
it's interesting to see that a lot of people are already collecting health data on their mobile phone. But I guess I always look at these questions and what we're doing in the projects, and then look at I guess, as an audience, we are people that will already be using new technologies. Whereas if you go into the general population, if I start talking to my friends outside of these projects, they're not so inclined. There's a big trust issue that needs to be overcome with regard to tracking still.
Yes, I think this part of the discussion we had this morning, Gary, is trusting the algorithms and so forth on that, and that's something we'll have to overcome in time. But that's it.
And I guess for the projects that are going to the hospitals, it goes beyond the user trust. It's also the clinicians that are getting the information back from the algorithms that the clinicians also trust. So we're supporting them. I'll be quiet now.
Yeah, no, appreciate it. We're running over time at the moment of time, so I'm suggesting we just stop this session. My thanks to everybody involved, including those who participated in the general discussion and those who were able to do the chat. We're going to go to just see this afternoon session. What we will do now, we're running out of time in terms of it, so I suggest we get back at 14:55. Is that okay with everybody? Say 14:55. This is the outline for the afternoon. Victoria, who you had the pleasure of hearing a moment ago, and Garza will talk very much about the ecosystem that they have in place, and with a presentation and also a demonstration, probably doing with Garza first of all on that area. Then we have Quality Top, and they have very much so a solution that I think they will be able to kind of share with us. They're doing quite a lot of good work in the area of AI, and they're doing very much so with leukemia and CAT-C cells. So that's it. Then we go to the final area, part of it, and as I said earlier on, without repeating it, we will have an engagement process. Now, I'm pleased to say, well, Gary, if you don't mind, Gary will participate at it. Gary is our project coordinator today, but I'm delighted to say he's winning his battle with cancer at the moment, so we're very pleased that he will participate in this again. So keep fighting, Gary. You're doing great, and you're an inspiration to all of us. So that's great. I'll see you all slightly later. We are now at 14:41. If we said 14:55, would that work for everybody? We say 14:55. That will give everybody time to get a quick cup of tea or do some emails or whatever needs to be addressed. So back online again at 14:55. I'll see you all then. Thanks. Hello, everybody. I hope you can hear me okay. And I'm just checking everybody's ready, and we will continue on. Zoraida? Yes, you're there. Thank you. Okay, so just before I introduce both Victoria and Gassan, who Victoria a moment ago you just spoke to on the gentle kind of conversation we had about clinical trials. Tomorrow we meet again, all going well, please God. We start at 10 o'clock live, so to speak, and we had difficulties this morning with the communications. That problem has been solved, and there will be a new link for you all. So we will give you that at the end of the session, and likewise, the email that you received from Alexandro will give you the details as well. So just please bear that in mind. There were some slight difficulties with the technology this morning, and we're trying to avoid a repeat for tomorrow. And so we will be giving you the details at the end of the session. And likewise, tomorrow the email you get directly will be the correct link. So now we're going to press on. We've got 3 presentations this afternoon from Persist, from Quality Top, and also we'll have the roundtable session. So I'm going to give the floor to Victoria in a moment. We will now just look at the Persist, and we're going to be talking very much about an ecosystem. Yes, and what Victoria and Gaza will be doing is talking about their Persist project, and also the whole area where they're focused on breast and colorectal cancer. I'll stop at this stage, and we will give the presentation to Victoria.
Thanks, Tom. And hello to everybody. I'm Victoria, I'm the project coordinator of Persist, and I'm going to make a very brief presentation of our project, trying to introduce what is going to explain later my colleague Asihan, that who will focus more in the visual aspects, the interfaces of this project. So, well, in our next slide, as you can see, this Persist project was a project granted by the European Commission in the frame of the H2020 program. It started in January 2020 and it will finish in February 2023. And in our next slide, you can see our 13 partners from all over the countries from Europe and also Turkey and Switzerland. Our main objective in this project, you will see it in our next slide. Our main objective is to address the unmet needs of colorectal and breast cancer survivors, while also helping the clinicians in their day-to-day work. So, which are these main worries, these main concerns that patients have? Well, the cancer recurrence, also the adverse toxic effects after treatment, and then these unmet needs that they usually think that are would be solved with a closed follow-up, also causes them some anxiety and depression. So, from the point of view of clinicians, they would like to be able to personalize the treatment and also trying to solve these problems that patients explain to them, and trying to tackle also the anxiety and depression that this situation causes to patients. So in the next slide, you can see our ecosystem and how we will use technology to try to solve these problems. We have a big data platform where many information from patients are stored. We ingest data from the EHR, the electronic health records from patients. This information is related to, for example, to comorbidities, also to the cancer disease, treatment, procedures. All this information is ingested in our big data platform. And also we have a health application, which will be shown later in this Persist presentation. These health applications connect with a bracelet that retrieves well-being data such as steps, sleeping, heart rate, blood pressure, and additionally, some questionnaires asked by a embodied conversational agent are performed, and also to trying to detect anxiety and depression, we ask patients to record some videos like a diary. So from those videos, we extracted through this multimodal sensing network some features and parameters that in the end will be processed by some artificial intelligence models and will point out some key points about the personal status, the possibility of being suffering anxiety or depression. So with all this information, we try to address as soon as possible the to early detect recurrence, adverse toxic effects, and as I said, anxiety and depression. And in our next slide, you can see how all this information is processed in the clinical decision support system, and all these key points are shown in a user interface, but for clinicians, not for patients. We always rely into clinicians to analyze if the AI predictions are right or not, and how to address the specific situation for patients, and which are the right measures to be to use for them. And I hope that with this you have a good overview of our project. And well, in our next slide, you can see how which are the means, the social media that you can use to follow us. And my colleague Athihan from Emoda Software will show the different applications that we have developed, and that is the most visual part of Persist. And I think that you will enjoy more than my presentation.
Okay, thank you, Victoria. So let me show briefly our apps here. We have a patient app, which is the main access to the Persist system for the patient. And it works harmony with the big data platform. And the one on the right is the clinician app that they use through the web. They share data through the big data platform. It's a secure system, so we respect their privacy and security a lot. So there's a PIN and password. They have to give consent to record any data, and only the patient's doctor can access their records in the big data platform. Data is ingested in the clinician app, their medical history and other things, and data collected in patient application. These both go to the big data platform later to be used in AI algorithms by other partners. Able to enter this manually if they track it some other way, because we did have some issues with some patients using these bracelets, like Victoria had talked about before in the previous talk. And we do have emotional status collection with a form. We tried many things here. We tried Plutchik's wheel of emotions, but it was hard to put it into a user interface. Then we landed up in a form like this. They do enter their emotional status. They record diaries, diary videos using a selfie camera of the phone. And there are the questionnaires that are on the server that are sent regularly to them for them to answer, and they can also get it and answer themselves. There are reminders, of course, reminding them what to do when there's a message from the doctor, when they need to record a diary, etc. We show these to them. So let me show you a quick video of it, and not to take a lot of your time, I'll try to make it a little faster, because these are the things that I just explained. So this is the clinician app. So they create a patient record here. And these data will be visible also in the app, in the mobile app. So this is the mobile app. They install it. They use the PIN code that were given to them later. Yes, right.
Can you hear us okay? Yes. I think maybe we have a technology glitch. Is there?
But I think that you are muted.
Okay, so I think I got dropped there for a second.
Okay.
Screen off, maybe. Well, it might help.
Sorry, so you can see it, right?
Yeah.
Okay, so after giving the permissions to the app from the device, they connect their Bluetooth device, the bracelet, and then these are the data that the clinician had entered. So they're greeted with some notifications, and then they see the app is empty, of course, when they start, but they need to do some things, and they start. We tried a bunch of things. We tried automatic collection from the bracelet in the background, but there were all kinds of issues with it. So we decided to, there was a process here. We decided to make it manual for the patient like this. So they sit down and then they let the device measure their blood pressure and other things in a explicit session like this. So once it is collected, it is displayed. And when they want to see what's going on, they can look at what's happening. This was also important because there were sometimes issues with the bracelet. They didn't know what's going on. So it was good to give them extra information. And if there is data, it is shown here like this. And they can provide their emotional status like this. And they can provide their diary recordings. They clicked on something here that required them to do these things in order. So they can watch it later. Only the clinician would be able to see it later. And it is used for depression detection and things like that by the partners who are focused on the AI part. I'm focused on this user interface part mostly. And there are a bunch of other things in the app. They can see their messages. They can see their the data graphs. And there's basic information which will be populated further as our project progresses. Knowledge base about cancer for them to, get information. And this is our questionnaires. They get to choose and answer. Also, they come in with notifications to them. They answer these questions. And it is recorded in the big data platform as they answer them. And of course, we have a CDSS which will be creating alerts as it sees things that are concerning, and it would be sending to the clinician's app notifications. So those parts of the project is ongoing still. So that's how they answer the questionnaires. And of course, there's multi-language support because we have patients from different countries, and they get to manually enter data as well. So I hope that's going to fill our charts a little bit. So if they have an issue with the bracelet or they somehow get this information, maybe at night they want to take it off because some patients do. So they can also enter their data like this about sleep and other things. So it's displayed in the charts, heart rate, blood pressure, as you would expect. This was supposed to say blood pressure, yeah. And so I can move further a little. They enter the date, they see graphs of this data, and they can enter new ones to see changes here. Yes, and the deep sleep versus general sleep is also accounted for. The bracelet sends this data to us, but when it's manual, they have to enter it like that. And yeah, they get to enter their steps, and it appears in the main screen. We are hoping to provide like goals that are set up by the clinician, but for now, this is where we stand with the app, more or less. Thank you for listening. This was our presentation.
Thank you. Thank you, Kasia and Victoria. I think it was a very impressive presentation, and I learned a lot. And I have some thoughts which I'd like to share with you, and then we take a look at the poll in a second. But my thoughts were in terms of patients, how many patients had you got in the trial you were doing roughly? Can you recall?
Yeah. We have 4 hospitals in the consortium, and they provide 40 patients, 24 breast cancer and 24 colorectal. So in total, 160 patients.
50 patients. Okay. In terms of time to enter the data, you said earlier on that they had to sit down because of some obviously technical difficulties of being in motion. How long does it take for a patient to complete the data and send it to you roughly?
Those who use the bracelet, they find it easy to use it. They only have to complete the questionnaire, and we never send those questionnaires too soon. I mean, maybe once per week we send them some questionnaires because we understand that patients would be bored if we force them to complete those questionnaires too soon.
Yeah.
And even though we would like to have the information close, so we notice any little modification in whatever circumstance, but we know that they wouldn't be bored, and I think that they shouldn't spend more than, don't know, 20 minutes per week, no more, if they use the bracelet. Of course, if they have to ingest data manually because they don't want to use it, it would be more.
Okay. So on the ecosystem, when you have the details coming in, forgive me, just staying with this thought, the physicians who are using the results, are they seeing value coming through? Are they seeing they've more time to do other things because the data is already coming through, that their decision making, what they're going to do that day, has improved? Or what are the benefits you're seeing coming through at this stage, Victoria?
At this moment, we are still developing some models for prediction. So we didn't want to show them, let's say, the alpha models, and we aren't showing them any prediction. They are just following reviewing the data, is what they can do at this moment, but they don't see any prediction. They will do it in our next phase of the clinical study, which will start by May, approximately. So I cannot give you any result regarding clinicians.
Victoria, I have a question. Tom,
Yeah.
may I go with
Absolutely.
a question? Yeah. So what about this information that you will provide to clinicians? Do you expect this to affect somehow the clinical practice? And if so, have you considered of the possibility of certifying your solution as a medical device?
Yeah, I don't think that we would go with the certification in the time frame of PERSIST, because this is a very long process, and you have to achieve a very accurate results. But of course, our intention is that all the predictions, the early detection of recurrence, or whatever prognosis we can do about also anxiety, depression, everything will help clinicians in their day-to-day work. Is our intention, is our goal. But certification is a very long-term process. So I don't think that we have roughly 1 year to finish the project. So I don't think that we could achieve it inside our time frame.
I'm asking this because we were involved in such kind of discussions in our Lifetimes project as well, because we also provide insights to clinicians, and we were, sometimes challenged by the clinical teams of whether we need to consider what we are going to develop as a medical device, and probably need to consult with, agencies, etc., national agencies, etc. So this is just a comment. Because we had to deal on ways of how the clinicians will interact in the end during the pilot study with the clinician's dashboard. That was my, my thought.
If your main worry is obtaining feedback about clinicians, of course, we are going to have some usability questionnaires for them, just to know if they find it useful, friendly, useful, because clinicians have a very short time to make.
That's true, and is a challenge. Is a challenge for all of us. Yes. I mean, we do not want to put more burden on their shoulders, right?
Exactly.
Yeah. Thanks.
We got another question coming in from the chat. It's from Nivida, and it says, "Can patients also create alerts from the app about their health?"
It's a good question. In fact, we discussed about that during our co-creation meetings, also with clinicians. And in the end, we decided not to do it because clinicians cannot review their application as soon as frequently as an emergency room, for example. So we didn't want to give them the feeling to the patients that PERSIST is in an emergency room. So we avoid this approach, and we clearly stated that if they feel unwell, or they feel that some important issue is happening to them, they should go to the emergency room. Because of this, we avoided to create alerts from patient side.
Victoria is very good. We've got one more question coming in from Panos, and he's asked a question to Gashem and also Victoria, and maybe Gashem, you can answer for a while. Gives Victoria a break. It goes, do you have any issues during the ethical application with PERSIST being a medical device? How did you circumvent them?
Well, probably Victoria would be better to answer that, but I can tell that the device is not, it's not giving medically accurate results. We are, using it, but not telling people not to trust the actual values, just to see if there's change in trends. So there I can see an issue, but please, Victoria, go ahead.
Well, as Gassi can say, since the device is not as accurate as a device, a medical device that would measure the blood pressure or heart rate, we just focus in following the evolution. So let's say that we see the difference between one day to another, and not just in the exact values. And regarding the, I don't know if Panos is thinking about the ethical approval in hospitals. Well, we went through that. Not sure if this question is also related to that, but if you are meaning that, we went through the ethical committees in hospitals. They were very concerned about how the patient information was going to be stored, if in some clouds like, Google or this kind of platforms. And once we explain that we have our a big data platform that for example, the bracelet, the device doesn't store the information. It's not a Fitbit device. So, for example, yes, talking about Fitbit because I saw it in previous presentations. It's not a typical commercial device. So all this information is not stored in a third-party cloud platform. It's everything in our platform. We went through the ethical committees in hospitals, and we didn't find too much problems to get approval.
Perhaps I'll ask the last question if it's okay with everybody, and then we just go through the poll. And my question is that who owns the data?
Yeah, we have signed several data transfer agreements. So the owner are hospitals, and they transfer to technical partners. We have signed individual data transfer agreements with the 4 hospitals, and once we finish the study, we will delete the information which is not used for the initial purpose, which is stated in the data transfer agreement.
Yeah, so beyond the life of the project, this is something you're going to think about, because during the clinical trials, I understand, but beyond the clinical trials, when say the solution goes to the marketplace, that process will be all taken care of in due course. Yeah. Mm-hmm. Okay. All right. Okay, and I think I get the picture. And Victoria and Kirsten, you guys have been great. I'm so sorry I'm rushing a little bit at the moment, but I know we're running out of time. You've been fantastic. We're going to do quick polls now. So if perhaps we can get the first one coming in. And as I said earlier on.
Can you see my screen, Tom?
Yes, I see it loud and clear. Welcome back.
Great.
So again, if everybody can do it, this is the first of 2 questions. Says, since you were a child till now, to what extent do you agree IT technology has improved the health services? This is a very general question, so I think anybody can answer it. Again, if you go to the Meniere.com, click on that, you should be bringing there, and this is the code number. It should work this time. I know we had problems a moment ago, but I think that should work. Shout at me, scream at me if you're having difficulties in using it, and we'll try to sort it very quickly. And I hate repeating like a broken record, but these poll questions are specific and they do help. Later on, we will analyze it. So I would encourage you to answer it. It does help us to look at it later on and try to get some general feedback, which will help us in our direction we're going to do in the various projects. So we're waiting for just a little bit longer. I count down to 15 and then we move to the next question. So 14, 13, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We're there. Can we switch to the next question, please? Okay, so this is the next question, and this is the final question for Persist. And again, my thanks to both of you. You've been brilliant. How willing are you to share your private health information with technical entities to help them in their research? Okay, I think we leave this one a little bit longer. Mixed reaction there. Please, by all means, keep coming on. I think it's a very important question. It's really poignant to what we're all doing in across multiple projects, not just do the Persist project. So please give us a response. We will look at this one carefully, and this is something that we may be able to use going forward when we're talking to the European Commission. So please stay with us a little bit longer, and then we go. Okay, so that's it. We will stop this again. My thanks, Victoria. Kashan, you've been guys are great. I love what you're doing. I think it's brilliant. The feedback you got, I hope is very helpful. We will now move to the second of the projects in this afternoon session, and this is going to be QualiTop. And QualiTop is a project that Delphine, whose project coordinator, is leading it, and it's very much doing with a cancer that is unpleasant, but it's there and it's been looked at, including cats or C. So I'm going to pass the floor, Delphine, to you with many thanks, and it's all yours.
Hi, good afternoon, everybody. Could you hear me clearly?
Yes, we're fine.
Yes, we can hear you.
Great. So I'm gonna share my presentation and just switch off my camera so that it optimizes the network. So good afternoon, everybody. And first, I thank the organization team and especially Tom and all the team for this great job and the fantastic opportunity they created through this event to communicate with all of you. So QualiTop stands for Monitoring Multidimensional Aspects of Quality of Life After Cancer Immunotherapy, an open smart digital platform for prevention and patient management. And it's my great honor to tell you more about this project. So first, why did we choose immunotherapy as the central scientific topic of this project? Well, you may remember that in 2018, actually it was almost at the same time the European Commission grant came up. James Allison in Berkeley and Tasuku Honjo in Kyoto were co-awarded by the Nobel Prize for their discovery of cancer therapy by inhibition of negative immune regulation. Well, both of them were studied T cell, and T cells are the immune cell in the body in charge of negative immune of the immune regulation, and especially in the recognition of self and non-self. And they were especially interested in proteins CTLA4 and PD-1 that function as the brake on the immune system. So especially antibodies against CTLA4 block the function of the brake, leading to the activation of T cell and attack on cancer cells. And antibodies against PD-1, as you could see on the graphic on the top right part of the slide. So the antibodies against PD-1 inhibit the function of the brake, leading to activation of T cell and highly efficient attack on cancer cells. So those two discoveries led to the transformation of the concept into approaches for treating patients. And this therapy, which is called the checkpoint immune therapy, is now considered as a fifth pillar to fight cancer after surgery, radiation, chemotherapy, and precision medicine. So actually brought major progress in treatment, resulting in high efficiency. And I show you there a few examples. And in melanoma, it's really striking with 60% objective response rate, and as well, for example, in acute lymphoblastic leukemia, 80% of the patients achieve complete response. And top of this immune checkpoint therapy, the development of CAR T-cell in hematology really offers new perspective for patients. So overall, the number of cancer patients eligible for immune therapy is really increasing. Well, nevertheless, it really remains a complicated option since it activates the body's natural anti-cancer immune response to attack and destroy cancer. It enables the immune system to cause immune-related adverse events by a specific mechanism, especially. And this make a real issue to predict the occurrence and as well the time to the occurrence of these immune adverse events. And the assumption that underline the project is that those immune adverse events really play on the quality of life of the patient. So it is in the project one of the interests. So overall, we have some data about immunotherapy results and immunotherapy adverse events, but they mainly came from randomized controlled trial. And in fact, it is quite well known that patients enrolled in a randomized controlled trial are not representative of the overall patients that benefit from the treatment. And also the real life is very different than the very standard procedures that happen in the trials. And that was one of the main arguments we used to develop a project in France, in Lyon, to have data on real-world data for those patients treated with immune therapy. Because immune adverse events can raise without any means for now for the patient to predict them and to prevent, we definitely need some pragmatic information about those events, as well information about quality of life, so that we could correlate those events and quality of life, and more precisely study the impact on health status. In addition, there are many stakeholders, of course, the patients, but also their relatives that support them in everyday life. Healthcare providers also expect tools to predict immune adverse events, better understand the determinant of patient quality of life. The health authorities wish to adapt policies, pharmaceutical industries wish to improve treatment, of course, scientific community need to some feedback to make progresses in the field, and general public have several and various expectations. So for now, we have identified 3 challenges that impede improving quality of life after immunotherapy. First, we need to determine what are the predictive marker and biomarker of immune-related adverse events and marker of quality of life, so that we could identify patient profiles and we could predict, prevent, and manage the adverse events, but also predict and promote quality of life of patients after immunotherapy, both for immune checkpoint inhibitor and for CAR T-cell patients. So to do that, we need to increase the knowledge on patients' real life, about their lifestyle, about polymedication, how they react, etc. And to overcome those 2 first challenges, we definitely need to bring diversity in data sources and increase the number of patients observed in real life. That's why the main objective of the quality of project is to develop and implement information technology-based European immunotherapy platform, so that we could use big data analysis and especially artificial intelligence, but also simulation and modeling causal approaches, thanks to the collection and the aggregation of those real-world data about quality of life, but you may understand as well about immune-related adverse events. We hope to monitor patients' health status and conduct causal inference in analysis, so that we could hopefully estimate the part of the immune-related adverse events occurrence in the determination of the quality of life of patients. This will be the steps to create harm reduction recommendation for patients and as well some recommendation and information for stakeholders, and of course we will communicate toward those different stakeholders, the different findings, and there are many to expect from this point of view. How do we work? Well, you could see on the left part the overall organization of the project. So there are some work packages, and the two main work packages for the collection of data are the one from a clinical point of view, work package 2, and the work package 3 with expert in psychosociology. So those two work packages will be directly collecting information from patients, and they could bring the information in a multicentric cohort instance of a patient treated with immunotherapy. Those data sources will be put together in a data lake, so they will not move from the data where they are, but they will be available for analysis, and they will feed the smart digital platform that is developed in the work package 4. The biostatisticians will work partly on the already existing data that are collected, and thanks to the analysis, they will estimate pattern of patient profile. They could raise hypotheses and learn from existing data to better analyze the coming prospective data. And those results could feed the work of the online analysis that are prepared by work package 6, so by the IT teams and data scientists. And they could thus feedback information and fuel as well all the causal loop that are created in the work package 7, thanks to which we could better understand and better leverage policies and model the evaluation of the impacts, economic impact as well of some recommendation. So the most important guidelines and policies will be selected from this work in the work package 7 to prevent undesirable medical condition, thus reduce immune-related adverse events and promote a good quality of life for patients treated with immune therapy. Of course, there will be some dissemination and communication to the different audiences, and we will adapt the format. So, as you may understood, one of the key words of the quality of project is multidisciplinarity, and it is based on existing collaboration that were enriched within the European Union, but as you can see as well out of the European Union with a partner from Harvard School of Public Health, especially dedicated in the simulation in the work package 7. So what do we expect from this project? First, we definitely wish to add new capabilities and add data to application for healthcare providers, but as well for patients. So, for example, visualize risks, trends or trajectory, and of course, combine multiple sources of data. So, from the healthcare providers, but as well from patients, and why not from the general public. For the healthcare institution, we aim at improving return on investment, especially in patient journey by streamlining internal patient quality of life projects and drawing on a pool of data and data processing nodes from a variety of innovative projects performed in other medical institutions, so mainly sharing information and meta information. For the public health point of view, we really wish to transfer ideas, functionalities, and workflow in ideally one integrated medical solution for monitoring health status and quality of life after cancer, improving quality of life, of course, promoting it, and widely disseminate to reshape clinical practice. For the results, we really aim at, thanks to the collection of information, give feedback to the patient and their relative on their risks, give them tips or recommendation, and as well communicate evidence-based results from up-to-date studies, because we have a specific objective about data curation. So we really wish to go up to this point in the communication with the patient and adapt the message to this audience. We will ease connection with peers, and this will be through the development of peer support web platform, kind of a social network actually. Give them some program, educational program, and allow us to register our participants as participants to the quality project. For the clinician, hematologist, oncologist, and any other physicians, they could learn about immune-related adverse events to predict and then to prevent. Symptomatic, then use some symptomatic treatment, and as well learn about patient behavior regarding self-treatment. And for the general population, of course, the information will be shared regarding metadata, synthesis of the most up-to-date information regarding quality of life after cancer immunotherapy and its determinants through the data curation I mentioned previously. As well, it will be important to communicate those policies and recommendations that will come up. And will as well be useful for scientists and policy makers. So probably we will go up to the data-driven analysis capabilities and the possibility for them to share as economic data, and conclusion and policies. So after about 2 years of project and almost 2 years actually of COVID pandemic, we managed to have a nice dynamic inside the project and have regular meetings between all the partners, and which is really useful because we have very different way to speak and to communicate, and we definitely need to have regular meetings between IT, clinicians, statisticians, and it's really a great dynamic. So this 2 years period enabled to have a first version of the conceptual architecture of the smart medical platform, and probably this summertime we will have a demonstration of this first version. We also have the first patient included both in the clinical prospective data collection and as well in a psychosociological collection in all the countries. And up to now, we have about 100 patients with immune checkpoint treatment overall included, and about 50 patients treated with CAR T-cell. The first analysis on the existing data sets exhibits some data characteristics which happen to be very important from methodological choice and in the comprehension, especially of the immune-related adverse events. So from this point of view as well, it was really great to be able to have those existing data and already get some hypothesis and some pattern from those data. And the first causal loop diagram was created, and it provides the foundation for a quantified simulation model, which could be used to forecast effects of policies and optimize resource allocation. So there are still a lot of work to do, but we are quite happy to have achieved those main steps in the project. So to finish, I thank you for your attention, and I share with you this picture of the kickoff meeting, because we are not really sure we could again have this very nice meeting by the end of the project, but we really wish to, and hopefully we will get rid of this pandemic so that we could meet for truth. Thank you very much.
Thank you very much for your excellent presentation and your presence at this meeting. It's always welcome when we have you on board. Thank you again. Brilliant. And please God, France will go on and win the Grand Slam. I think it'd be great for all us nations over here in Ireland. Well done. So I want to talk to you about your presentations if I can. What can you just confirm to me, are there 4 hospitals involved, or is it 3? I couldn't quite recall how many's involved in terms of actually participating in it. Which is it like trials in different countries? I wasn't quite sure.
Yeah, absolutely. Yeah, you're right. I forgot to mention that. Actually, the clinical centers that enroll patients in the study are France, Spain, the Netherlands, and Portugal. So we have mainly 4 countries involved in the enrollment of patients and in the data collection. And from those countries, and in addition from countries that are not directly a clinical center, we have already existing data. So UK, for example, have some data they are working on, so that we could raise hypotheses and already perform some analysis on those existing data.
What was the biggest challenge? I mean, I would have thought the simulation model would be quite challenging for this specific project. But is this where the area that you're finding most difficulty, or is there some other place that you're finding more challenging?
Excuse me, I misunderstood your question.
I was wondering where the difficulties exist, because I know where you are at this stage, and I've looked at your website on several occasions. But I was wondering, was the simulation model the hardest part of the project, or was there another part which you found more difficult than others?
Actually, no. For now, it's not really the simulation part which is the more challenging, because simulation are mainly on this economics part, and as I mentioned about the causal loop diagram. So it's a really hard work, but they are really trained in this kind of approach. So I'm really confident about that. For the analysis part, for now, the main challenges came from our ability to collect enough data to be able to have to have a model giving results converging, because when we go through specific immune related adverse events, there are not so many. So we have a lot of immune related adverse events, so we can work on this, and we already get some very interesting results. But we are not for now in the situation that we could have specific analysis per type of immune-related adverse event. So for now, from the analysis point of view, this is probably the most challenging part.
Okay. When does the project actually end, per se? Can you recall? I was trying to understand where the project would end, and is it 2023? Is this correct?
Yeah, you're absolutely right. In fact, we had some more time because of the pandemic, especially because at the very beginning of the pandemic, I don't know what happened in the different countries, but in France, we really had to reshape the whole way patients were care at the hospital. So here we really had to face those kind of reorganization. So I have to say it's slightly slow the progression of the project, and for now we are a bit late in the project, but thanks to the European Commission attention, we could have a short time additional.
Yes, I think this is very common for most projects because the COVID had a huge impact on their ability to kind of go forward. Excuse me, I have a frog in my throat at the moment. So yes, it's very true. So is there any you'd like to ask any of the audience specifically in regards to your project? Is there any concern you have?
Actually, I think we have the question in the poll.
Yes, so we can, if it's okay, then we'll drop over to the poll now. Definitely, if it's okay with you. Despina, are you okay organize the poll? Can we just do it now? Okay, so we will go straight to the poll. And as I said earlier on the previous presentations, these questions are being written specifically by the projects, and what we're trying to do is get some feedback. And so the more people who respond to it, I think the better, and the more solid the questions are, the feedback is. So I think you all at this stage understand. Go on to Mentimeter, put in the code that allows you to vote. The first question: how useful do you think the implementation of a European immunotherapy platform using big data analysis and AI is for cancer patients? Okay, so they're very short replies. We'll stay here a little bit longer. Please feel comfortable. As I said, the more people that get respond, the more solid the response, and therefore definitely can make judgment calls as the project goes forward. So please, we stay on here just a little bit longer just to try to help the project go forward. So overall, so far we're saying it's very useful. It is really encouraging. Well done. So, okay, so we go to the second question, if you may, just now. So if that's okay, we go to the second question and see what the feedback is. So we're going to switch over now to this next question. Now it reads, Friday, do you agree with the following? I trust and feel comfortable with the use of my personal data by doctors, researchers, experts for use. And it's a nice question.
I actually, this is really an issue with GPDR and sharing the data. So despite the fact that we went through the IRB in each country, we still have this question about how we can really work together at the European scale. And I could see that some of the challenges we have in the project are shared with FACE. So despite the fact that we plan to have those online and distributed algorithms, we still have to think what if we at some point need to share some data to be able to go further.
I think it's very important. And one of the things we're going to be doing in the cluster, which we'll explain tomorrow, is that we're going to identify the common data types and try to have shared data sets set up that we can all work across on our projects going forward. And likewise, we can link into other systems that are out there. I do apologize, my throat seems to be full of a frog at the moment. So we won't be doing this. So I think this is complementary to what you're doing. But overall, there's the feedback we get at the moment that's not a lot of people are 100% fine with this. It's like it's somewhat seems to be the way we're getting it, but we use the analysis later on. So I think that's been a great presentation. That clears there. I'm very happy. Is anybody any other questions at this stage for Delphine? If not, what I suggest that we will do is get ready to organize the roundtable session. I'm not sure is Panos here at this stage. Have you arrived? Okay, so this is all rather new, and I'm delighted to say that we will have a completely different approach to what we'll be doing. Rather than we listen to projects being presented and explain what they're doing and try to get some feedback, we're now going to go to a situation where we bring patients, carers, and physicians to speak with us, to listen to them, to engage with them. So it becomes very much of a dialogue session of engagement and taking it from there. Panos will lead this. I'm not sure. Is he on the call at the moment? Is you there?
Yes, I'm here, Tom.
Oh, I'm delighted you're there because I wasn't quite sure. Did I have to step in? So welcome on board. So I'm just going to explain a little bit about it. I'm going to pass the floor to you. So you can see our colleagues who have kindly come aboard. I can see Elena on screen at the moment, and it's great to have all of you here today. So what we're now going to do is do a few things. The first thing is Panos will do the introductions, and then he's going to open the floor to all our colleagues from the patients, and I'll step back now, Panos, in a second, and then we're going to ask the audience, and I'll not taking the thunder away. We're going to ask some of the audience to engage, and this can be verbal. So if you want to use the chat, you can, or you can use verbal just to get it going. We take 3, and then what's been organized that each of the projects have to date pre-prepared questions that they would like to engage. We have the floor of about an hour or so. It doesn't matter to go beyond it. But the principle of this now is let's talk, let's engage, let's not hold back. Let's try to get the discussion going, and we can all learn and share this knowledge and understanding together. I think this will be very appropriate as we move to day 2 tomorrow. So with that, I'll stop talking. I give the floor kindly to Panos. Thank you very much, Panos. The floor is yours.
Thank you, Tom. First of all, I would like to thank everybody for entrusting me in moderating this session. It's a very important session, and I'm very happy and grateful to have 6 representatives of patient and patient advocacy members here today. Myself, Panos Papachristou is my name. I'm a medical doctor. I'm also a representative and partner in the Life Champs project, which is part of this cluster. So I will play a very background role here. So next slide, please. The focus here are the 6 representatives that we have today. Alina, and we have Anita, Despina, Gary, Jan, and Gary and Jan. And Roalinde, I'm sorry. So with that said, I would like to invite our representatives for the patient roundtable to just say a few words about themselves. So should we start with Roalinde, please? Would you like to say something about yourself?
Yes, hello. My name is Roalinde Middelveld. I'm from Stockholm in Sweden. I'm a breast cancer patient. I was diagnosed with breast cancer about 6 years ago now, and I'm currently still on hormonal treatment. And I'm involved in the breast cancer patient organization Amazona in Stockholm, which is an organization I represent here today.
Thank you, Roalinde. Welcome. Anita, would you like to say something? Some words about yourself, please.
Yes, I can do that. I have to leave soon, so I don't know how long I will be with you. I'm sorry, and I have told you that. But I am a member of the Amazona board, and I had my breast cancer 2008, and I'm still on treatment. So yes, that's me.
Thank you very much. We're sorry that you cannot stay for longer, but anyways, Gary.
Hi guys, so forget what I said earlier. earlier I was the FAITH project manager. Ironically, in the middle of last year, I was diagnosed with stage 3 skin cancer, and I'm actually going through treatment at the moment. And interesting, the Qualitar project, I'm actually on immunotherapy. So it's 12 sessions and I'm halfway through it.
Thank you for sharing that, Gary, with us. Thank you. Welcome also. Jan, the floor is yours to say some words.
Yeah, very nice to meet you all. My name is Jan Geisler. I've been a cancer patient now for 20 years, was diagnosed at the age of 28 with leukemia. I've been on treatment for 13 years. I've been on a phase 2 study with 2 experimental treatments. I've since then engaged in patient advocacy, been a co-founder of a number of pan-European patient organizations, current chair of the work group of European Cancer Patient Advocacy Networks, or WeCan. Was coordinating EUPADI, the European Patients Academy, in its first 6 years. And in my former professional life, that's probably interesting for the issue of artificial intelligence. I worked in innovation technology management for media company and for Vodafone in R&D, where we did a lot on technology and innovation. I did the business model. So that's my other life, which I've left behind quite a while ago. But that's why I have quite some interest in the whole area of data, artificial intelligence, innovation, and so on. So it's really great to meet you all.
Thank you. We move along to Alina. Who's next?
Hello, and it's glad to see you again, even if we are speaking virtually. From the virtual point of view, my name is Alina Comanescu. I'm a patient advocate from Romania. And I could gladly say that I could benefit from the right to be forgotten because I was diagnosed with breast cancer 15 years ago. And for the almost 9 years, I've been actively advocating at the local level, national level, and European level for various types of cancer. My association is a member of European Cancer Patient Coalition, Lung Cancer Europe, and Digestive Cancer Europe, and I am actively part of patient expert panels with ERTC, and since last year August, I'm also member of the Independent Data Monitoring Committee.
Thank you, Alina. Welcome. And finally, Despina. Kalispera, Despina.
Kalispera. Hello. Hello, it's a great honor for me and for Alma Zois Thessaloniki. I'm a scientific director, psychotherapist, and social worker from Association of Women with Breast Cancer, Alma Zois Thessaloniki. I design, supervise project about psychosocial support and education programs, screening interviews, psychological assessment, individual consulting session to breast cancer, sponsorship manager, and organize conferences, training, and supporting group for women with breast cancer. It's very pleasure for us to be here today. Thank you very much.
So thank you all for being here. We're very grateful to have you here in this roundtable session. So next on the agenda that Tom has prepared also, I think it's a short presentation of the projects that have not been presented today. So just a 2-minute presentation of 3 of the additional cluster projects. So am I expected to share the screen here? Or I can do that if it's needed, but it might take a minute.
I think Sarita, you have this stage, Sarita, don't you? Excuse me.
There should be presented from the projects from tomorrow. Clarify. Yeah, Escape and Rebecca.
So maybe it's just for Ionis, would you mind just doing the quick presentation on the Rebecca, please, straight away, and take the screen. I'll try and have that.
Thank you, Tom. So let's So our project is Rebecca. You will see the presentation tomorrow. So very quickly, Rebecca stands for Research on Breast Cancer-Induced Chronic Conditions supported by causal analysis of multi-source data. And our aim, our main goal is to improve the quality of life of breast cancer patients and breast cancer survivors. And we do this by having two overarching goals. So the first one is patient management. We want to improve interventions or care choices at the individual level. And the second one is the clinical research aspect. We want to analyze data and better understand how treatment affects quality of life.
Sorry, Ioannis, we don't see your slide.
Yep. You cannot see my slides.
Just a blank screen.
Just a blank screen. So I have shared my screen, but you cannot see. Okay. That's weird. I cannot understand. For some reason, Zoom shows a blank screen.
Shall I share your presentation for tomorrow if it helps, like even if I pass it quickly or something?
Yes, sure. But right now, can you see something right now? No.
Sorry, no, at the moment. I understand. Perhaps what we're trying to move on and allow you to come back to it if you want to just take a look at this. So
okay.
Yeah, it's probably best to do. So can we take a look at Clarify? Eric, I'm not sure who's doing Clarify specifically. Do you have the slides ready for tomorrow? Oh, sorry, for this afternoon? Oh, it's Maria. Hi, Maria. Thank you.
Hi, everyone. I'm Dr. Maria Torrente from Hospital Puerta de Hierro in Madrid. We are coordinators of the Clarify project. And yeah, let's see if I have more luck with the sharing of the screen myself. Let me see. Okay, can you see the Clarify presentation now?
Yes.
Yes.
Very clear, thank you.
Good. Okay, so in our case, Clarify stands for Cancer Long Survivor Artificial Intelligence Follow-up. What we want is to identify in an early stage factors that usually impact the survival and prognosis of three types of prevalent cancers, which are breast cancer, lung cancer, and lymphomas. They are especially breast and lymphoma. They are long survivorship cancers, and recently in the last 10 years also lung cancer, given the latest treatments. What we want is to, with the use of different data sources and artificial intelligence tools, try to establish a personalized follow-up program for these patients, as there are no follow-up guidelines for these long survivors, and they just, they have a lot of unmet needs that we find in the consultation. So we want to analyze different characteristics of our patients, not only clinical, but also prems and prompts that we obtain from quality of life questionnaires and wearable devices that we use with our patients. And with all of that, develop predictive models that we will have to classify or stratify these type of patients in terms of the risk of developing toxicity, secondary malignancies, or any kind of other pathology or comorbidity, secondary or not to the treatment and to the primary tumor. For these we have different, our cohort of patients come from our hospital, and we have breast, lung cancer and lymphoma patients. We gather the data from the clinical notes molecular data and also wearables and that control the sleeping quality and the physical activity and a bit the circadian rhythm of the patient. And we include all of these data in a dashboard that allows clinicians not only to obtain the clinical outcome of the patient, but also correlate it to all of these other data sources that we are obtaining, and with that make more integrated and multidisciplinary approaches or interventions to the patients in order to adapt their follow-up. Okay, so our main aim, well, these are the questions that I think are for later. So what we are trying is to involve more to get a more involvement from the patients in their health, and with these tools, especially the dashboard, to gather all the data sources that we can obtain from every patient, and again, not only focus in the clinical information related to the tumor, but also get other data that also assists us in better follow-up, in a better choice of post-treatment approach, and a better also not only for the patient but also for the caregivers. So in this sense, we want to provide to cover all these patients' specific needs.
Thank you very much. So do we have the final project also, I think, ASCAPE?
Yes, hello. Let me open my camera. Hi, I'm Christina Stratigaki from the ESCAPE project. I'm the project coordinator of the initiative. Let me share my screen. No, it's not visible. It doesn't let me to share my screen. So I will move forward into describing the project. So more info will be given tomorrow in the detailed presentation of the project, but ESCAPE follows the same path or a parallel path, let's say, with the other projects that were presented here today, and stand for through artificial intelligence to support cancer patients across Europe. Of course, apart from the use of ICT technologies such as big data, AI, and machine learning to improve the quality of life and the overall health monitoring of cancer patients and survivors, we also examine how these use of technologies can disrupt the iron triangle of health, which is quality, cost, and access. So we are also trying to position our work and research and the ESCAPE platform and the use of AI and big data technologies, and relate that research with the socioeconomic impact and what is the background of the patients across Europe, what is the status in different countries. That's why we have as pilots different European countries such as Spain, Sweden, and Greece onboarded in the project to help us do such kind of research as well, because it was mentioned earlier, and I think that it is quite important for this round discussion to also discuss the socioeconomic impact, the financial status of the patients across Europe, the different legal framework, the different practices that are followed within different hospitals, what is the cost, and what is the actual access to healthcare and follow-up for cancer patients, which is a very diverse environment across Europe. So if I have to describe in a short term the technical solution of the ESCAPE, let me just focus on the aspect that ESCAPE really focuses on the privacy and security of patients' data. We know that it is a very sensitive issue, and we are trying to handle it accordingly. So from a technical perspective, we have managed and accomplished to do all the collection, storing, and processing of the data only locally within the healthcare existing infrastructure, which means within the hospital. So the data never leaves the hospital. We have a cloud solution as well, combined with the edge servers and the edge nodes, which are the hospitals, onboarded in the Escape platform. But in the cloud server, let's say, or outside of the hospital, no personal data are published. So all the processing and the training of the data is done within the hospital. So the patient gives consent to the hospital to get on board in the Escape research during the recruitment process, and then the hospital is responsible, along with technical support from our side within the consortium, to collect, store, process the data, and of course to respond to a very common question that I saw earlier. The data owner is the patient, but the controller of the data, as long as the Escape durates, is the hospital. So at any time, the patient has the right to withdraw their consent and drop out of the research and the clinical trial. So we are trying to follow a very user-centric approach with regards to quality of life around breast and prostate cancer. This is the main focus. But the long-term vision is to be able to accommodate and examine quality of life parameters in other types of cancer. But the main benefits for the patient is to improve the counseling, let's say, and the guidance, and also the bonding and the relationship of the clinicians and the doctors with the patients on a very regular basis. Actually, one of the initial findings of the recruitment and the clinical trials that are still ongoing is that through the Escape process, with all the questionnaires that the patients fill for quality of life parameters, and through the use of wearables, they have more often communication with their doctor, with their appointed doctor, either by phone or physically if is necessary and is permitted due to COVID restrictions. So the ability to have remote access to healthcare counseling is a very great benefit of Escape. And also another benefit is the identification of disease trajectories and relapse, and the early diagnosis and forecast of ill health. Sorry if I talked too much, and sorry for not being able to share my screen at the moment, but hopefully I'll give you a quick overview of our project. Thanks.
Thank you, Christina. Looking forward for the full presentation tomorrow instead. So we need to move on to the next session, which is the actual Q&A session. I also have a Zoom issue here. I need to restart my Zoom if I am supposed to share my screen and slides. I don't know if Tom or somebody who is assisting can share the actual questions, but the idea is that we have the Q&A questions from the chat that we are going to start with. So I guess I have.
You should have. You have the right. You have permission to.
Yeah,
share.
I have the permission, but because I'm on a different computer, I need to restart my computer or the Zoom. Should I do it? I can do it, but.
No. So
it
what?
appears that if you restart, maybe you fix the problems. I had the problems, and now I can share my screen.
Yes.
So.
Thank you. Shall we go with that, Panas? We let I introduce Rebecca project.
So just a quick for Rebecca.
Yes.
Okay. So just very quickly, our objectives are patient management, how to improve interventions or care choices at the individual level, and clinical research is how to analyze data to better understand quality of life. These objectives are very common with the other project as well. So what we do in Rebecca is that we want to access multi-source data in order to multiple real-world data. So we are currently building our Rebecca 360 platform, and we are accessing electronic health record data, smartwatch data, and we have mobile apps. Actually, we have 2 mobile apps, one for the patient and one for the companion of the patient, to also provide data for the patient. We have a new technology, that's the web browser plugin that we will see tomorrow, through which we can monitor the online interactions of the patient. And also we combine all this data with the local environment of the patient using maps and other external data sources, and through which we can quantify the life space of the patient. So very quickly, this is our main pipeline in the Rebecca. So first we rely on monitoring. We have the continuous and objective monitoring through applications and smartwatch and the browser plugin. We have the self-report data, and we have the traditional clinical data. This is everything that, such as blood exams and standardized questionnaires that you collect in the clinic. From this point, we move forward and we provide some high-level indicators using the recording data. These are variables that indicate how the certain aspects of the behavior, of the emotion status, and the clinical status. And the final step that is very important in Rebecca is the causal analysis of the data, that we aim to find causal links between these indicators and the health status of the patient. And also we want to map these indicators to something that we call functional index and emotional index, that are comprehensive comprehensive scores of the patient status, through which you can acquire in-depth understanding of the quality of life, and also you can use the system for example, to have an early detection of the symptoms, such as alerts, like other potters said, and also, of course, to design improved interventions for the patients. And what's in for the stakeholders? Very quickly, for caregivers, they can access detailed information about the patient through day-to-day monitoring of the behavioral, emotional, and quality of life for the patient. And for the patients, we can provide them with interventions and healthcare that is tailored to them, and it is based on their current status. And if we identify early signs of deterioration of some behavioral or emotional status, we can adjust the treatment accordingly. And of course, for researchers, we can provide more tools, data-driven tools, to study cancer and the complex array of comorbidities and disabilities. And the questions I have has them already. So thank you very quickly.
Thank you. So I think then we can try to move on to the no. I'm sorry again. So there seems to be an issue with the screen share again.
Panos, I will share for you.
I think that will be the best. Because also, Despina, you are also monitoring the chat, right? Or
yes, but as we are in a round table discussion, we can leave it more interactive, I would suggest.
Yes.
Okay, I'm sharing my screen, and please confirm that you can see the right file.
Yes.
Okay.
Thank you. So the idea right now is first to welcome questions from the attendees. So if you have a question, raise your hand or start speaking.
Because I would suggest maybe what we would do, because given the time we're at this stage, perhaps we should go directly to some of the questions that were in the individual projects, and we try to get through as many of them as possible. And then at this stage, I would strongly encourage, please, everybody in the audience, engaged. Please tell us your opinion. Work with panelists and try to come up with something that will help us. This is the whole purpose of today's meeting, and this session specific is to listen to people in the audience and to try to get dialogue going so we can go forward with our projects. And we really appreciate your help in this. So it's back to you, panelists.
All right. So. I think these questions, we have gathered questions that all the projects agreed upon and are relating to all the projects. I can start asking Jan, if it's okay with you, Jan, about the first question of how much of a barrier do you consider technology when embedded in the routine care process of patients with cancer in particular, and also in particular adult patients with cancer?
No, sure. I'm happy to respond to that, even though the 4 questions here are different questions than we received yesterday, but that's okay. I have a lot of thoughts about any of the questions here, but in terms of the barriers, I don't think there are specific barriers. At least the barriers have changed over the past 10 years because we were assuming that elderly people can't use technology. And I think that's more or less over because we see 70-year-olds using iPads for all kinds of things. And technology has become very accessible. But the problem is that it creates new vulnerable populations, especially those that are financially less viable. We've seen that in COVID with telemonitoring, that it's great to offer telemonitoring and all these things, but if it's only open for those that can afford to buy tablet computers and iPads, which often the financially less well-off community doesn't have, then you're actually leaving those behind that used to receive services the traditional way. And that has nothing to do with their age or their education level or something like that. It's mainly their financial capabilities, which is a main barrier. I think the second barrier is that people don't see the value, because also what I saw in your presentations is that you're very focused on what the healthcare system has on it. So a very indirect benefits of the patients, that by receiving better care and the clinicians know better what they're doing, and you're collecting better data about quality of life to support them. But my experience with apps and these things is that patients hate them unless they see a value for themselves and a very direct benefit. So we're asking them to feed a machine with their quality of life data and click on their symptoms and click on their side effects and tell every morning how they feel. But there's no feedback. They're not seeing what they're answering. They're not seeing themselves, how their constitution has changed over time, what their main problem is, and how often they had headaches last month, or migraines, or symptoms of a specific drug or whatever. So in the end, it just informs the systems, the clinicians, the healthcare providers, the system, the insurances, and generates data. But the value to the patient is always a very blurry promise of you will receive better care. And I think that works for a month or two, but then people forget about putting on the smartwatch or feeding their app in the morning just because they don't see it's benefiting them anyway and doesn't really empower them. And as a reviewer for these kind of calls because I act as a reviewer for the European Commission as well as for the German Ministry on all kinds of AI and innovation calls, I always ask the question, so how does it empower the patient themselves? Why are decision support systems not empowering the decisions the patients take and just empowering the healthcare providers to take decisions on their behalf and improve the consultation maybe? And I think that's probably the highest barrier, which is caused by that these services are not being co-created by patients. Patients are usually just involved as beta testers when the service has already been designed and half developed. And when patients then say, I don't like that, I don't think it provides anything to us, then they get the response, but it's too late to change that now because we're already halfway through with development. So do you like the front screen, or can we change the sentences or the coloring, or do you think the icons are right? And this is not, this is where most apps fail.
Thank you, Jan. Yeah, very valid comments. Thank you for sharing. Roalinde, would you like also to comment on this and maybe also to touch upon the next question about the trust? So it's the barriers and the trust about these new technologies that are being introduced, and also AI that is on everybody's lips for the last years here now. So
yes, thank you. I couldn't agree more with what Jan was just saying, actually. About, something there has to be a benefit for the patient himself by using these new technology, a clear benefit. And also, I think it's very important to involve patients already from the beginning when developing these new tools. As we've now, I'm not sure if that was mentioned before, but in the Breast Cancer Association Amazona that I am a member of, a volunteer, we participate in the Rebecca project that was just recently presented. And what we've done there as a patient organization, we've taken an active role right from the beginning through getting input from our members. So I think it's very important to get input not just from single patients when starting to develop these new technologies, but to make sure that you get the input from a broader group, so you know that you're not missing any important information. So what we've done in the Rebecca project is that we've organized focus groups. So we've invited representative groups of patients to discuss, especially in particular, the types of questions that are being discussed today. Which type of data are patients willing to share? How do they feel about the security of the storage of the data? Who can get access to the data? Who's in control of the data, etc.? These types of questions we have discussed with our patient groups. We've also sent out a questionnaire to a larger group of our members, all breast cancer patients, where we've got information about technical aspects, like which kinds of phones do they use normally, which kind of computers, which kind of browsers, which social media do they use, etc., just to get information about what is actually possible, what do they use, and what are they willing to share. So I think that's really a point I would like to make, is to really involve the patients in an active way. When you develop these products, and not at the stage when the app is actually already almost finalized and it's too late to make any changes.
Thank you, Rolinda. Yes, I agree also with you, and I've seen that you're an active partner in the Rebecca project. That's really a huge benefit for Rebecca to have you on board from the beginning as a beneficiary in the project. So and also to engage your stakeholders, your patients, in the patient organization on a national level, but also on a European level, I guess, also.
Yes, indeed. And I want to say that for Rebecca, the fact that all these actions have been from the beginning, we have started with the patients to have all these meetings and all these surveys have provided tremendous feedback and understanding how we can create something that they want to use and they will be helpful to use. And it's very important to include them early in the process, yes. And Amazon is doing tremendous work in this part.
Yeah, what I would also like to add in terms of developing these technologies, that it's all very well to have great apps and technologies to get lots of data out of it, but in the end also the healthcare providers actually need to be prepared to use the data and also to actually use it to improve the treatment of the patient, because I know healthcare providers usually are they lack time, they don't have enough resources, the doctors don't have enough time. So if that doesn't match with the new technology, then in the end, it's questionable how much use it then will be for the patient, rather than not more than a self-aiding app, which could be useful in itself. But I think it's very important that healthcare providers also are able to deal with this technique as well to help the patients.
Yeah, just Gary here. I think it's like, just to reiterate what everybody's saying, I think it's important that the co-creation process starts at the start of the project, but follows right through to the end. We're not bringing in stakeholders at the start, getting their opinion and then walking away. They need to be involved at the development stage and also in the trials and also in going to the market. It just means that the research projects then have a good grounding for going out into the market. And that'll bring me back to when at the start, when you're looking at the co-creation process, I think the projects have to be cognizant of what the stakeholders and the end users are looking for and not stick rigidly to what was originally proposed. Okay, you can do the technology, but you also need to work with the market to see what's required, or else it's just a research project for the sake of finishing something and then it goes on the shelf and you move on to something else. I think you need to keep everybody involved from the start and take their opinions on board.
Thank you, Gary. Very true. And from what you said and the insights from Rolinde about question 4, then is it self-explained? Then question number 4 about the low participation in clinical studies. Can we rephrase that question, and what needs to be done besides, I mean, including patients from the beginning? Or is it another barrier that patients are not willing to participate in a lot of clinical studies? What is your opinion, Alina?
Thank you for giving me this.
If you would like to answer this, or you can pass as well to.
Yes, I would like to answer this because it's my area of expertise. I think that first and foremost barrier in enrolling cancer patients in clinical trials is the problem of education and communication. Because I've seen being involved in various patient advisory board, the discrepancies in access and willingness to be enrolled in a clinical trials between Western Europe and Eastern Europe. So this is the first problem that, in my opinion, should be tackled, because maintaining this gap between the two areas of interest is detrimental for Eastern European patients. So I think that maybe with also bureaucracy plays a major role in limited patient access to clinical trials, and I'm hoping that the implementation of the new directive on clinical trials will ease a little bit this bureaucratic approach existing in Eastern Europe.
Thank you, Alina. Despina Manzieri, would you mind switching to the next slide, to the next page? I would like to ask our panelist, Despina, about question number 6. So Despina from Alma Zois, about the integration of different decision support systems with patient engagement strategies. Would it be useful, and what kind of patient engagement strategies would you suggest?
Well, I totally agree with other colleagues, but I would say in this question that anything that creates a climate of trust and direct contact, especially with the elderly, is a serious commitment for us. Is something that we see in our association, that especially elderly human needs to have a commitment. They need to have direct contact, more information, and they worry about personal data and the complexity of using some of it. Then they don't feel it very. They don't have a trust to something they don't know, and they don't know how to use it. So they need more information.
Thank you. Does any other from the panelists have an additional comments or strategies that would work?
I mean, probably if I may, just to comment on that, and that relates to an earlier comment I made. The decision support systems are at the moment very much designed to support the clinician in, let's say, the decision making that he or she should then do with the patient. While in fact the decision support system should support shared decision making, which actually means, and that's what I see in many proposals out there in the area of artificial intelligence, that they actually have just a healthcare professional interface. So they process a lot of data from all kinds of sources and guidelines and whatever kind of thing to actually recommend based on probabilities and parameters, recommend, for example, therapeutic approaches or diagnostic approaches or whatever. But in the end, the patient might feel more alone because they feel there's now the doctor and the machine that actually suggests the best way forward for me. But they don't understand how the black box and the doctor actually come to that conclusion, that it relies then strongly on the communication strength of the physician to explain how he or she and the machine actually came to the conclusion. And that's why I always advocate for having a patient interface. Of course, that needs to break down complexity. You don't need to talk about genetic probabilities and gene-gene interactions and whatever in, let's say, what is explained to the patient. But how, let's say, the decision support system actually comes to specific conclusions and what kind of data it has processed, and how, let's say, the algorithms actually came to that supportive conclusion. I think there can be a patient interface. And when patients come home with a recommendation from their physicians, to go back to the system and actually see what's in there and actually make sure that they're taking the right choice for themselves would be tremendously helpful. And of course, that requires a specific level of literacy. That's not for everyone. Some people just say, I trust what the doctors are doing. But people like me and many others with cancer that have a single life and one decision where you need to decide on left or right, feel quite uncomfortable if they don't understand how the recommendations came about. So they want to have access to those decision support systems, probably in a different granularity too. And to do that, I mean, patient engagement strategies, it's the same like we've been advocating for with EUPADI in drug development for years, that patient engagement needs to happen at the design stage for those systems, and then probably think about patient interfaces to those systems too, which probably is not so much effort and probably a side product for the clinicians, but probably a very important one for those that should benefit from the solution.
Thank you, Jan. Alina, did you have some comment on this as well?
Yes, it was the same idea as Jan's, but I also, because we are talking about co-creation, I think that one important strategy is asking involved patients to review outputs, because this is how, in my opinion, this is how you empower them and somehow co-involve them in the co-creation activity.
Thank you. For the organizers, do we have time? One more question. It's
yes,
it's quarter to 5, so I was concerned about the time. So the last question there, Rolinde,
thank you.
Which kind of incentives, we touched upon this subject again, but about the incentives or the motivation should be offered to cancer survivors in order to participate in the design and research of these innovation products and innovative solutions.
Okay, can I say something about this, Despina from Alma Zois?
You're welcome, Despina, and then we can pass the floor to Rolinde as well.
Okay, I believe that in a way, these people need to feel that in a deeper context, someone cares, and even though they have stopped their treatments, and they're still protected. A more direct contact, and as much as possible to create a framework of trust and relationship with result focused on their aftermath and care would definitely be strong motivators, I think.
Thank you.
This is Tom. I mean, please continue. I mean, the conversation you're having at the moment is tremendous. Don't worry about time. Talk away. This is a very, very important way to do it.
Rolinde, do you have any reply on this or any comment? Considering also that you are part in an European project as a beneficiary.
Yeah. Well, what we found is when we asked our members to participate in the focus groups and questionnaires relating to the Rebecca project, we found actually that there was a very high interest among our members to participate, which was very positive. And I think what's very important is to give clear information about why you want to collect data and information from them, and also to explain clearly what would be the benefit for them in the end as well by providing this information. And I think that's very important.
May I extend this question? So do you see some specific patterns according to age or gender when it comes to participation in research projects?
Well, according to gender, I guess was a little difficult for us as we only invited females. But in terms of age, when we organized our focus groups, we had two different age categories. One group of women under the age of 60 and one group of women above the age of 60. I think now I'm not sure I remember exactly if there were big differences. I don't think actually there were, in that sense, in the way that they were willing to share information or in the way that they are used to using iPhone or smartphone or apps. And
did you find any difficulties during recruitment of these two age groups?
No, I think that it was quite similar actually.
Okay. That's interesting.
Both age groups were interested to participate.
Mm-hmm. Even if you had to do with a technology-based project, yes?
Yes.
It didn't play any specific role.
No, not as far as I can. I don't think so. No.
Mm-hmm.
I think you'll find what's happening is people that have gone through say the situation are willing to help to kind of help people going forward and people that get cancer in the future. I think that can be the motivation, because the impact that it has on your life, you want to avoid it for other people.
Yes, but I think it's very important also, maybe it seemed to be relatively easy for us to recruit the participants in the beginning, but I think in order to keep them motivated and to keep them active in the co-creation process, I think they have to keep on see the benefit of it. They have to see the progress, and probably also they would like to see that whatever information they provided and viewpoints that they are actually, maybe not all are used as such, but they feel that they are listened to.
Exactly. Yeah. And that's where you'll see it at the very end, when if you keep the same group from the start right through to the end and you're listening to them, you'll see the end product will actually have their inputs taken on board.
Yeah, exactly.
I mean, I can only add to the incentives, even though it's not always easy to talk about money, but if you want to involve people in your projects, make sure there's a budget for their time. Because I mean, you can of course do a focus group or an advisory board a year, but that probably gives you some kind of insights, but it doesn't really give you the constant flow of input while you're developing these solutions and while you're trying to find out where you're going. This is hard work. And let's say getting advice here and there can be made by volunteers. But if you really want people in your work packages, in your review teams, in the people that constantly look at user interfaces or algorithms or communication or visual designs or whatever, this is hard work. This takes hours and hours and hours and hours. And I mean, cancer patients usually have cancer and they have a limited lifespan and very limited energy. And if you want to convince them that they should spend their days and days on working in your project, you need to have a budget for them, or for their organizations, or for the organizations that employ staff that help you doing the day-to-day work while they pull information from cancer survivors in their network. and so on. And that's probably one of the deficiencies I often see in these proposals, that there's budget set aside for the staff members of the consortium to do the work, and budgets for travel to meetings, but no budgets for actual workload that people need to do. And I know it's complex with subcontracting and with whatever, but I mean, we've been doing this in Harmony and IMI-SysEqual and other EU projects where we have budgets and compensate patient advocates for providing their time and advice in the projects. And I think that should be foreseen.
Yes, I couldn't agree more. In the Rebecca project that we participate in, we actually had a budget to employ a qualified project manager who works for us. And that's been really, really very good. It really has helped us to do the work that we have been able to do in the project. It wouldn't have been possible without that.
Yes, thank you. Thank you. Coming back to we go back and forth between those two question pages, but there was a question that we skipped from the previous page about the aspects of daily life of healthcare. So for yourself or for the patients that you represent in the patient organization, what aspects do you think can actually be improved by using technology? Maybe we touched upon it earlier, but are there any specific aspects like collecting data through Fitbits or wearables or a mobile application from the patient perspective? Gary, you have any thoughts on that?
Yeah, I guess you're looking at the patients of how much they actually use data as well. Say from my side, I like looking at data, so I'm watching. I'm monitoring the whole time. I have watches that I wear on my phones, but it depends on the patient themselves and how much they are I suppose a data geek, so to speak.
So, but is it only about this IT literacy, or are there other factors that I mean, about the trust issue or the just the?
Yeah, well, I suppose to get users, you have to overcome the trust barrier. You have to prove to them that their data is protected and there's no data leaks or anything like that could happen when they're using. When you're transferring the data around, you have to prove that the data is going to be safe with whoever's using the data beyond the devices themselves.
What I could add is that what we found as a result from the focus groups we've had is that the patients would like to be in control of which data actually is being transferred. And they would also, many of them would like to see the possibility that to maybe close it off for a period of time as well. So they would like to be in control of which data is sent and also when and when it is not sent. I think that's an important aspect as well.
And that's actually part of GDPR. So the whole right to withdraw your data from such a system is a headache for everyone who provides these services, but has been established for a good reason. I think with all the technology and blockchain, whatever, there's a lot of possibilities to actually implement that for those that actually want to pull back, because that increases trust. Probably almost no one will do it, but you know that you can, and then you actually feel much more comfortable. I think what patients are increasingly scared of is what we've seen with companies like Health Unlocked or patients like me, which have collected huge amounts of very personal data on rare disease patients and personal conditions. And then suddenly these companies which were started by patients and were driven by a mission, were then sold to some obscure investors. And suddenly you have a second data set in China, as it happened with Health Unlocked and with patients like me. And that's what people are scared of, that suddenly their genetic and health information is just being sold. And with GDPR, that's hard, but it happens. And to rule out that things like that happen, that patients own their data and they can withdraw and they have a right when these things happen, I think that's important to think about in design, because you never know where these companies go in 5 years' time.
Yes, But it's what has come out of what when we talk to patients, not just that they want to be able to withdraw data that has been collected, but also maybe if it's an app on the phone that continuously collects data, to be able to switch it off for periods of time, so that no data is collected.
I was part of a focus group on the GDPR aspects for cancer patients, especially lung cancer patients. And one question that came from a patient was bedazzling. It was about the biomarkers and the biobanks. And he asked the organizers, what happened with my my tissue and my information after I'm dead? And everybody went blank at that question, because it was I don't know, it was an aspect that was not even covered by the organizers. So that's why it's very important to involve the patients. Okay, involvement, it's a based concept, but to involve him in the co-creation of anything related to its personal data.
Thank you. True, and a very important aspect of GDPR and what is happening with technology all over Europe. I mean, like also considering pioneer countries like Estonia, who has implemented this in their whole society, from tax payments to healthcare visits, and the right to be forgotten and the right to choose what data to share to which authority. So do we have any other comments? I invite the project participants to also add spin-off questions on the topics we touched upon, and ask our panelists for some input now. Take the opportunity to ask them input so they can take it with them to the different sprints in the projects and use it.
I think another important point for the patients is the simplicity of the information that's being shared, and I guess education of the patients. There's lots of information out there on the internet, but say from my experience, if I was looking at, as I said, I'm going through immunotherapy, so I started looking for information about immunotherapy, and there's quite a lot of research papers out there, and I'm lucky that I'm coming from a research background, that I can find this and I know what to do with it. But I think if the layperson was looking for it, it mightn't be as easy to get information for themselves. So I think a big point to raise is around education and sharing of information, and keeping it as simple as possible.
Do we have any other comments from the audience? Any project-specific questions the audience wants to ask our panelists?
I think panelists,
I think we can conclude this session then. I'm very thankful. Thank you so much for our 6 patients. Anita couldn't make it to this session, but for the 5 of you, thank you very much.
Thank you for participating.
Thank you very much for participating. Thank you from Almazois Thessaloniki.
Thank you very much, everyone.
Thank you. Bye-bye.
Thank you very much, guys, for everything you've been here today. Jan has gone, so our thanks to him when we see him. Panels, thank you very, very, very much for stepping in. Very late notice. Unfortunately, Charis was going to do this, could not make it, and very, very much Pansis jumped in, and for all intensive purpose, I think today's afternoon session, specifically on the round table, has been enlightening. It's been much information sharing, and the detail we've gathered has been exceptional. I hope you all enjoyed the participation, and I hope you all can get a better understanding of what our projects are doing, and maybe in the future we can do something like this again. I think the opportunity to do this will be there, and the more engagement that we have, I think the stronger our outputs. And I'm very keen to make sure that we do come up with something. So if it's possible, I won't talk about any detail, but it would be really nice to do something like this again as we move with our projects forward. So for everyone at this round table today, personally, thank you all very much. On behalf of all the projects, you've been great. Thank you all most sincerely. And panels, once again, thank you for stepping in.
No, thank you. Thank you. It was my pleasure. And the important aspects from all the representatives, the patient advocates. So I think it's very, very important not to stress that, not enough. I mean, all the comments made.
So I have the pleasure of saying we're finished for today. It's been a long day. It's been challenging ways that behind the scenes you weren't all aware of, but we managed to get through it. And with your kind thoughts and contributions, I think by and large, much knowledge, much understanding has been shared, and we do it. And as I said in my earlier slide, yeah, we're going to show you, we're going to listen to you, and later on we're going to start evaluating and bring it forward, the knowledge into what we're doing. So that's what we're going to do, we will proceed all of that as we move forward. Can we, if it's okay, Sarita, can we go to the closure file? We've done the Q&A session, which is good. So tomorrow's session, we're going to just give you a quick introduction for tomorrow. So look, tomorrow is also going to be quite a wonderful day, I think. We have the pleasure of inviting Barbara Kersen, who is the head of the R&D department in there. And what she will do tomorrow is introduce what they're doing at policy level when it comes to patient participation. And this is what we're trying to encourage. We really want all our solutions to come through to be very user-centric. So this is the principle of the cluster, is underlining, and I've spoken to Barbara previously, so she knows where we're coming from. So she will present tomorrow. And then, as you saw today, very briefly today, the Aspect project, the Rebecca project, the Clarify project, it was done very quickly. But tomorrow we have more time to talk to you at a more controlled manner. We will do demonstrations tomorrow on these projects where we can, and also we have time to exchange thoughts through the chat, but also maybe on a more dialogue basis tomorrow. So I'm truly looking forward to that. And Kathy from the European Cancer Patient Coalition will give an understanding of patient engagement at clinical trials. So I think this is going to be good. Tomorrow again, we also use the lunch break, the tea breaks, as a matter of give us a break and go check out whatever emails might come to you, or take some phone calls and grab a coffee tomorrow. And then by lunchtime, if any stuff that needs to be taken care of, this is probably the time to do it. In the afternoon, just to close the session, Antonius and I will have time to talk to you in a more relaxed manner, because we've been rushing quite a bit today to try to keep the schedule. And we're going to explain to you what we're doing in the cluster. And it's not just about today's event, about the cluster. There's a lot of more stuff, a lot of more interesting stuff going forward. And we're going to show you our plans for this year, and then who's doing what and so forth. So I think you're going to show us where we're going, showing you tomorrow where it's going. And I think you'll find that enduring and pleasant as well. And then finally we close. So I'm seeing you all tomorrow, please God. We open up at 10 a.m. CET time. We commence at 50 minutes past 10. Hopefully there's no problems with communication. So again, what we're going to do is show you the new link. So if you've seen a previous link which given you details, please ignore it. This is the link. The link is also in the channel, and the password keyword is there. This is what you need tomorrow, and we will close it now, I think, at this stage. So I'm going to wish you all a pleasant evening. I will gladly have an Irish coffee when I meet you all at some stage in the future. But just for tonight, I can't wait for stories. And thumbs up. I'm looking forward to meet you all in person. This is remarkable because although we've been working together for over a year, we have yet to meet in person, which is the strangest comment I can make, but it's true. We've actually have had so little time to engage. Everything's been virtual, so we're hoping at the end of this month, maybe we will meet the European Commission. I'm planning in Q4 that we will have a chance to enjoy an Irish coffee or a beer or a drop of wine, whatever is on me. So we will do this, please God. But for everybody who is not part of the cluster group, you know about us at this stage. We will become more visible this year, and we will try to get more engaged from the outside world to help us with our work. And that's it. So I thank all my colleagues who helped. Despina, who's been working in background mode on the chats, and also helping out in the Zoom questions along the way as well. To my God, Sarita, it's been wonderful in background mode. We've also got Alexandra, who's been doing a lot of work in terms of social media, who's been very strong and helping us put us all together. We've one more day to go. I know we've a lot we can build on. So let's all link up tomorrow if you all can at 10 a.m. CET time, and we'll make tomorrow as good as we possibly can. So thank you all, everybody, and please God, I see you all tomorrow. I wish you a really pleasant good night.
Good evening.
Thank you, Tom.
Bye-bye. Thank you all.
Everybody.
Bye-bye.
Thank you, Tom.
Thanks, everybody.
See you tomorrow. Bye.
Bye, everybody. Thank you all for coming. Thank you all very much for coming. So Rita, may I grab you and Alexander for about 5 minutes? Is that possible straight after this call? And we just get organized a bit for tomorrow. Okay. So maybe what we best need to do is just we'll set up a little Google Meet, and I trust we stop recording at this stage. I think that'd be nice to do. Sorry. Of course. Thank you. Okay. So what we will do is that we pick it up now in Google.